Masal Khair. As you know, I'm working in the British Council, the head of science there, so I'm lucky enough to get to see all of the different research projects that the British Council is supporting with the STDF in Egypt, which is now about 35, so covering a broad range of topics. And the thing I always find really fascinating when I come and see a project like this one is the idea of bringing, for example, like Professor Kevin here, who's saying it's the first time they've come and worked in the Middle East and North Africa region, and they've picked a great country he's picked a great country to do that, being Egypt, being such a large and always been producing such great researchers. So I think it's always very fascinating to see when researchers can come together for the first time and use previously thought through subjects and then developing it onto something even better and will be able to benefit the Egyptian, ultimately Egyptian people. So for me at the British Council working on this, it's always a privilege to see that actually the tangible benefits from this sort of research and seeing the support that is given by the universities and the senior academics. So it's thank you very much for letting me be here and hear about what we've been doing.
Thank you. Our next welcome note from the Dean of the Faculty of Medicine, Ain Shams University, Professor Mahmoud Mekini, who is also Professor of Hepatic Surgery, one of the most renowned hepatic surgeons in Egypt.
Thank you, Tariq, and good evening, everybody. And I really feel delighted to be among you today in this very special venue overlooking the Nile. As you can see, beautiful views. So I think you've chosen the best hall in the city. I hope that our visitors and from England and from Canada enjoy the stay here, enjoy the weather. Autumn is very nice, and actually the best time to visit Cairo and Egypt in autumn. So we have a very nice weather. So if it's your first visit, please enjoy as much as you can the historical and the monumental history that we have. I want to thank all who collaborated to make this event and this research project and Center of Excellence in Ain Shams University. Being a Dean of the Faculty of Medicine in Ain Shams University, I'm actually delighted that we're starting to see centers of excellence in research. As you all know, the ranking system all over the globe is being more and more advanced, and we didn't think about that some 10 to 15 years ago, and we start thinking about that only in the last 5 to 7 years, and it happened that we found ourselves as we thought always, and we still believe and very proud that we are one of the oldest universities, not only in Egypt but in the region and the Middle East. And most of the doctors running all medical practice in the Arab world and Middle East and some even European countries used to be Egyptian in the history and even in the recent history. But we found ourselves out of the ranking for a few months, I would say, until just 3 to 4 years ago when we started to be inside the first 1,000, first 800, and we are working on it very hard. And one of the reasons that when we dig in the details, why are we not in the first, for example, 500 universities, although the Faculty of Medicine of Ain Shams in the first 350, I must say, but we carry the brunt of the whole university of the 17 faculties within the University of Ain Shams. We found that we have a problem with research at large and with citation numbers per faculty, because we have a very big number of faculty members in our faculty and university, and when we put the citation in relation to the faculties, we had a little problem there. It's getting better day after day by work like this. So what I'm trying to say is that these research centers and excellence, centers of excellence especially, is really within our master plan and our target as a higher administration of the Faculty of Medicine of Ain Shams. So I would like to thank taking this occasion and this opportunity, Professor Tariq Okasha, Professor Hisham, Samar, Minen, and all the forensic and psychiatric departments, in Ain Shams Faculty of Medicine, and as well those working in the Ministry of Health in the Psychiatric Secretary, is that right, the name? General Secretary within the Ministry of Health, because we cannot do this job without them, and this would never have seen the light without the support of the important bodies that have been always supportive to us, like British Council, SDDF, and collaborating with University of Nottingham, which is, I know that's a very renowned Faculty of Medicine university in England and in Europe. So again, another privilege. So taking the efforts of all of these bodies and people and professors, I think will end up with a very successful program, very successful 2 years research program and project. And it will pour into our interest, which is getting better, which is in the best interest of our faculty, and I'm sure this will give us some more points in the ranking system as the Faculty of Medicine and as a university. I'm just a blue surgeon, as you heard from my friend Tarek Al-Kasha. So you can imagine as a psychiatrist that how a poor surgeon could be quizzed between the forensic on one side and the psychology on the other side, or the psychiatry on the other side. One of the, or two of the most important and I would say demanding department within my faculty that I'm running. So again, I would like to thank them all, and I wish them all the success and a very fruitful meeting. Thank you very much.
We'll hear a welcome word from Professor Manan Al-Maqsood, the Secretary General of Mental Health and Addiction Treatment in the Ministry of Health in Egypt. And also, before you say something, I would like to welcome Dr. Hisham Abdul Hamid, the Director of the General Forensic Authority of Egypt. Welcome, sir.
First of all, I would like to welcome you all, and I'm delighted to be among my professors and colleagues in this marvelous event. And I think it's a very significant event in the history of forensic psychiatry, and it will push the forensic psychiatry research forwards in the future, in the near future. And this is what we care a lot about in both in the Ministry of Health and in our dear University of Ain Shams, Faculty of Medicine. My pleasure is to stay at the same stage with my professors, Dr. Tarek Al-Kasha, and my very special professor, Dr. Hisham Rami, because he was doing very great in the post I'm put in now, and I'm very happy to continue on the same track, I hope. And among my professors, Professor Mahmoud Al-Mitaini, who is known by his interest and support for all types of activities, especially activities of research, and with Dr. Hisham Abdul Hamid, who is one of the brilliant doctors in the forensic psychiatry, and he's doing very well with the forensic unit. It's marvelous to have this crowd, and I'm very happy to share with our full power team in General Secretariat of Mental Health in this activity and the activity of the training, which are very important nowadays and will be very important in the near future. I'm looking forward to seeing more research and more activities and more trainings to improve our services and improve our research ranking. Thank you very much.
Finally, a welcome word from Dr. Hisham Al-Hamid, the Director General of Forensic Authority in Egypt.
مساء الخير. اولا انا بعتذر شديد الاعتذار عن التاخير، دي المواصلات بتاعتنا، ده طبيعي يعني. انا برحب بيكم جميعا، وفي اللقاء اللي انا بعتبره حاجه جميله جدا ان هم يضم كل الهيئات اللي موجوده دي، يعني مبص الاقي جامعه عين شمس، الاقي مع مصلحه الطب الشرعي، مع الامانه العامه للصحه النفسيه، مع البريتش كونسل، مع الصندوق الصندوق بتاع الابحاث والتكنولوجيا. يبقى اذا 5 جهات ممثله، تمثيل جيد جدا جدا. ده يخلينا نفكر ازاي ان احنا ندفع البحث العلمي فيما يتعلق بالامور النفسيه المتعلقه السلوكيه، الطب الشرعي النفسي الجنائي، ازاي ندفعها في مصر دفع صحيح. احنا في مصلحه الطب الشرعي بنتعامل مع ضحايا في الصحه النفسيه بيتعاملوا مع الجناه. يبقى اذا احنا ممكن نكمل بعض بشكل جيد جدا، ازاي نعمل بحث علمي متطور على كل ما يتعلق فيما يتعلق بالجرائم وعلاقتها ومدى التعويض عن العاهه النفسيه. لانه احنا حتى الان للاسف لما بنيجي نتعامل مع اي عاهه بنتعامل معاها من الناحيه الصحيه فقط، من الناحيه البدنيه فقط. لكن مهم جدا ان احنا ندخل موضوع الصحه النفسيه كجزء هام جدا في العاهه المستديمه. عشان كده انا بقول ان هذا الاجتماع بالنسبه لي انا شخصيا اجتماع مهم جدا، انه من خلاله نقدر ندفع البحث العلمي بحث جيد جدا. طبعا فرصه عظيمه بالنسبه لي ان انا اتقابل مع الاساتذه الكبار، الدكتور محمود المديني له باع كبير جدا في كليه الطب ما حدش يقدر ينكرها. الدكتور هشام رامي انا سعيد جدا ان شفته النهارده، بقالي 2-3 ما شفتوش. دكتور عكاشة شرفت بلقائه، وحاجه من الشخصيات اللي احنا بنعتز بيها في الطب النفسي. دكتوره منن، وليست منة واحده فهي منن كثيره، فانا التقيت بها يمكن مرتين بس شرفت ان انا عرفتها. طبعا الدكتوره سمر انتوا عارفين ان هي عايزه تاخد كل حاجه من كل حاجه، فهي مش مشكله. وسبق اتكلمنا في الموضوع ده مع طبعا انا شايف عمالقه قاعدين تحت، اساتذتي كلهم قاعدين تحت، يعني مش عايز اكبرهم يعني. دكتوره منى قطب والدكتوره دينا شكري واساتذتنا كلهم من كل الجامعات المختلفه، فمش عايز بس اعجزهم يعني. فانا بقول ان احنا فرصه جيده جدا. دكتوره سمر قدرت تجمع الناس دي كلها. فرصه جيده ان احنا نفكر ازاي نتحرك في البحث العلمي الصحيح في اتجاه صحيح، لانه فعلا احنا تاخرنا كثيرا في هذا المجال. فارجو ان احنا ننظر له نظره صحيحه. متشكر جدا على هذه الدعوه الكريمه.
Finally, we're going to have a welcome note from Dr. Samar Ahmed. Sorry, before that, Hisham, I'm sorry. Dr. Hisham Rami, please. Professor Hisham Rami is Professor of Psychiatry in Ain Shams University, and for the past 5 years he was the Secretary General of Mental Health and Addiction Treatment in the Ministry of Health, and Professor Menon took over nearly 1 month ago. So we'd like to thank him for all his hard work, and we'd like to wish Menon all the best of luck. And since this year in Egypt is the year for women, so we're very happy that Menon is the first woman to be Secretary General of Mental Health, and hope she will not be the last one.
الحقيقه انا بشكر الدكتور طارق جدا على دعوته الكريمه، وانه اداني الميكروفون اخيرا بعد ما تناساني تماما. بشكرك جدا. والحقيقه الواحد فخور جدا انه قاعد على نفس المنصه مع العميد بتاعنا، وده حاجه احنا بنعتز بيها جدا في كليه الطب جامعه عين شمس. والحقيقه انه غير ان الاستاذ الدكتور محمود المتيني هو العميد بتاعنا، الحقيقه هو واحد من اشطر الجراحين. انا حضرته وانا امتياز، لما كنت امتياز وشفته بيشتغل الحقيقه، فيعني حقيقي يعني راجل مميز. الحاجه الثانيه ان هو راجل اجتماعي وله سوشيال نتورك، يعني حاجه نفخر بيها ان يبقى العميد بتاعنا هو الدكتور محمود المتيني. حاجه ثانيه بفخر تاني ان صديق عزيز ليا جدا اعرفه بقالي دلوقتي 5 سنين، هو الدكتور هشام عبد الحميد رئيس مصلحه الطب الشرعي، وتعاوننا كثيرا في مجال الادمان ومجال يعني وحاجات كثيره جدا. فانا سعيد ان هو موجود النهارده معانا. بشكر طبعا زميلي واخويا الكبير الدكتور طارق عكاشه. احنا حضرنا نيابه، يعني حاجه اسمها نيابه اللي هو طبيب مقيم مع بعض لغايه ما كبرنا مع بعض. ثم افترقنا قليلا وهو اكل الاكل كله وانا ايه فضلت العب رياضه. ويعني الواحد سعيد جدا انه موجود، وفعلا زي ما الدكتور هشام عبد الحميد قال فكره التعاون بين جهات مختلفه عشان نطلع منتج جيد في النهايه ده شيء جيد جدا، وخصوصا لو ده انعكس على ما يقدم للمرضى. الحقيقه في مصر في مشكله كبيره في الطب النفسي الشرعي، وهي التشخيص والتقييم جيد جدا دلوقتي، والناس فعلا بتعمل تقييمات رائعه، ولكن المشكله ماذا بعد ذلك؟ الناس بتتحجز في اماكن وتترك هناك بالسنوات، ودي المشكله الحقيقيه في مصر. فلو هذا المشروع اللي بيشترك فيه جامعه عين شمس، بريتش كونسل، صندوق التنميه والتكنولوجيا في وزاره التعليم العالي، جامعه نوتنغهام، ودلوقتي كمان معانا حد من كندا كمان اللي هو عامل هاو تو اسيس ذا ريسك، مدى خطوره المرضى. لو هذا المشروع مش فقط انتهى بانتاج ابحاث، ولكن انعكست تلك الابحاث على الخدمه المقدمه لهؤلاء المرضى اللي انا بقول عليهم غلابه، وانتهى الموضوع بوجود خدمه تقدم للناس دي في المجتمع فيخرجوا من اماكن الحجز او المستشفيات اللي هم بقى لهم فيها سنوات طويله، ده فعلا هيبقى حاجه تصب في مصلحه الوطن عامه. والدكتور محمود بيه طبعا عاوز الابحاث، فيبقى جزء ده اساسي، والجزء الثاني برضه ينعكس يعني فعلا على جوده حياه الناس دي، لان حرام انهم يترموا للسنين كده. وبشكر الدكتوره سمر فعلا انها دينامو وقدرت تعمل الكلام ده، وشكرا جزيلا ويا رب تستمتعوا.
شكرا دكتور هشام. انا ما نسيتكش انت في القلب، احنا مع بعض بقالنا 30 سنه، فالموضوع مش محتاج. طيب I'd like to ask Dr. Samar Ahmed. I will not say that she's from the forensic medicine department with Dr. Mona here. I will say that she belongs to both departments, the forensic department and the neuropsychiatry department, and we're going to take her over to our department. خدوها. طيب. And Dr. Samar, as Dr. Hisham mentioned, has been working very hard. She's the dynamo behind all the work that's been done between being able to bring all these different authorities together, writing up protocols, taking care of financial issues, taking care of logistics. She's doing all this very hard work and making us all feel that things are moving smoothly. But I know that this is a lot of stress for you. But we thank you for your stress and for your achievement. And you're going to give us a small presentation about the LIFE project.
Thank you, Professor Tariq. First of all, I'll be speaking only for 3 to 5 minutes, not more. I understand that our Dean has other very important commitments, and I'm very thankful that you were able to pay us this visit, and this is your event, so thank you for having us. I just need to thank everybody who offered assistance to this project. I'll start first by Professor Mona Musa, the chair of our department and the star of this event. In my opinion, her support is invaluable. She's been giving us support and giving us a lot of leisure to do what we crave to do. She never stops anyone from being creative, so thank you for that. I'd like to thank everyone in the room and all the authorities that have come together, as Professor Tariq has already outlined, to make this project happen. The LIFE project is a project that we wrote together, Professor Birgit and I, from the University of Nottingham 3 years ago, and we threw for funding. And we hoped that we will get a response, and the British Council kindly responded. They accepted our project. It was one of 7 projects that were accepted in that call, and the STDF accepted our project for funding, and it was funded under a scheme called Mutu Musharrafa scheme. We got very good funding. I don't need to say the number, but we have a good number that we can, yes, exactly, that we can actually expand on research. And we were speaking, Professor Birgit and I, that there are so many projects where so many events are taking place and a lot of money is being placed in events and travel, and no research comes out. So no, our project, there will be research coming out of our project, thank God. So we will have 2 to 3 publications coming out. One of them is due these days, so we probably will have something published really soon. And the beauty of this publication is that it has University of Nottingham, and the General Secretary of Mental Health, representing the Ministry of Health. So it's an expansion outside the walls of the university, and this is something I'm really proud of. We have many events planned. One of them will be taking place by the end of next year. Another International Forensic Psychiatry Day, where we will be trying to make this a habitual annual event. Hopefully all of you will be there, and we will be able to recruit many other participants as well. We've done a lot of work. We're halfway through our project, and we're expected to expand our project for another 2 years, Daniel? 2 years with extra funding. So this is what we want to do. 2 years with extra funding. So if we can double the funding over another 2 years, we will be able to produce very valuable work, because now it's different than any time before. The General Secretary of Mental Health is our very dear friend, Professor Mona, and based on that we have many other plans to expand our research to be as useful as possible and as useful for the patients as possible. We need outcome that's useful for our patients as well as for our citations, of course. But we need our patients to really benefit from the outcome of our research. So this is it with the LIFE project. Please endorse the LIFE project. The LIFE project, you know the logo of the LIFE project. Please endorse our project and endorse all our other projects as well. Thank you very much for having me.
We will be starting now our scientific program, and our first speaker will be Professor Birgit Vollum, who will be she'll be talking about the forensic services challenges in the United Kingdom, and she is from the University of Nottingham, one of the important collaborators in this work.
Thank you.
Oh yeah, the slides are coming on now. Can you hear me okay? Or we're just waiting for people to say their goodbyes.
Yes.
Should we start?
Yeah, can I please just make an announcement first? Can I please just make an announcement? There is translation, double language over there. If you need translation at any point of time, please use the earphones. لو أي حد محتاج ترجمة للساينتفك توكس أو كده، إحنا عندنا سماعات في ترجمة، فبليز بس روحوا خدوا سماعات من هناك and use them. Okay? Thank you very much.
Okay, thank you very much for inviting me, and thank you very much for Samar for finding me as a partner for this LIFE project. I'm very pleased to be here in this wonderful city of Cairo and also be a partner of this very important project. I've been very impressed with the people I've met here so far, with their enthusiasm and compassion for patient care as well as for research, and I think that's a very good mix for making a successful project out of our LIFE project. I will be talking about forensic services in the UK and point out some of the challenges we face. I'm talking about that because that's the service I happen to know, so that's not by any mean to mean that we know it better or the way it's done in the UK should be copied anywhere else. I'm actually not from the UK myself, as you might have figured out from the accent, but I think it's very important that we learn from each other, so I think you can learn from some of the things we do, and we can learn from some of the things you do, and then in the end we'll have a better service for all of us, for our patients, and also better research. So, just try to figure out how that works. Yeah. So I say a little bit about the legal system and the Mental Health Act. I hope it's not too dry, but I think it's important to place the service provision in the context of how people get in and out of those services, because that determines to a large extent who you actually find in your services. I'm going to say a little bit about how in the UK quality assurance is done, how services are monitored for the quality of service provision. I say a little bit about service user involvement, which might be unusual to you or maybe not, but I think it's important to involve the people who are receiving the services in their design. And I will say things about opportunities and challenges probably as I go along, but also at the end, and I hope we can then later on in the discussion spend some time to compare good and maybe not so successful things about our services in the UK and here in Egypt. So when I talk about the Mental Health Act and the way services are delivered, I'm talking mainly about England and Wales, because the UK, as you know, consists of various parts, and Scotland and Northern Ireland have somewhat different services. So it's mainly about England and Wales I'm going to talk about. So as you will probably know, in the UK and in England there's a common law system which is based to a large extent on case law, where the law is developed by judges through the decisions of the court, which then provide a precedent for future decisions. So it's less dependent on statutes but more dependent on case law, which has the advantage of being more fluid and more responsive to changes in societal values, but has the disadvantage that it doesn't really separate the powers and doesn't involve the parliament in the law making, because it's to an extent made by the judges by their judgments of different cases. It's also an adversarial system which has advantages and disadvantages as well. So you have two different sides fighting, bringing their point across, as opposed to having one judge to take all the evidence in and make the decisions. The jury determines the verdict, and then the judge passes the sentence, and the trial will only be conducted if the accused pleads not guilty. Some figures about the UK system, and these are definitely things not to be copied. The age of criminal responsibility is quite low in my view. It's 10 years, which is the lowest within Europe. I know the systems in Europe better than obviously in other parts of the world. I think it's 12 years in Egypt, if my Googling came up with the right figure. 10 years is actually quite low. The incarceration rate in terms of prisoners per 100,000 is amongst the highest in Europe, with 146. It's actually the highest in Northern and Middle and Southern Europe, before Spain, and then other parts of Europe, and particularly the Scandinavian countries have much lower figures of imprisonment. So it is actually a society that places emphasis on punishment and on incarceration. It also is amongst the highest numbers of life sentences and indeterminate sentences within Europe. Again, another thing not necessarily to be copied. So looking now at the legal provision for mentally disordered offenders, this is regulated within the Mental Health Act, not within the criminal law, but actually within the Mental Health Act, which is the same act that governs the detention of non-offending psychiatric patients. And the definition of a mental disorder according to the Mental Health Act in England is any disorder or disability of the mind. So somebody, in order to be incarcerated or detained, whether or not they have offended, has to have a mental disorder, any disorder or disability of the mind, which is a rather loosely defined definition. So it doesn't talk about specific disorders like schizophrenia, it doesn't talk about a specific severity of disorder, but it keeps it quite broad, which has again advantages and disadvantages. It can capture a lot of people who might need treatment. On the other hand, it might capture possibly too many people who might find themselves being detained. There are some exclusions and exceptions. For example, people with learning disability are only considered. Well, it will go away, potentially.
Oh no, it goes away here. Hang on. Yes. Yes. It's okay. Don't go ahead with it. Right. Okay. So let's hope that doesn't happen every 2 minutes.
Okay, fine. So learning disability is only considered to be a mental disorder if it's of a larger degree of severity associated with aggressive behavior or irresponsible conduct. And dependence on alcohol and drugs is actually excluded. It's not considered a mental disorder within the Mental Health Act in England. Again, this has advantages and disadvantages. It is seen more as a behavioral choice, I guess, of people rather than a disorder, which has the disadvantage that people with mental disorder, with substance misuse disorders, get probably less services than they would otherwise get. They can, of course, be treated voluntarily, but they couldn't be admitted against their will on the basis of their dependence on alcohol and drugs. So this is what a mental disorder is in English law. Then general criteria for detention, this is for any patient regardless of whether they have offended or not, is that they have a mental disorder, as I just said, which is of a nature and degree that makes it appropriate to receive treatment in hospital. Again, you can see it's rather vague. Some people would say too vague. Nature of or degree, that can be anything. It doesn't specify it has to be particularly severe. It talks about the detention being necessary for the health, safety and protection of others. Again, it doesn't say that the risk towards self or others has to be severe or imminent as it does in other legislations. It does have a provision though that the treatment in hospital should be the last resort, so treatment cannot be provided unless the person is detained, and treatment has to be available in the hospital. This is also important, so the law doesn't allow somebody to be detained and then not be treated. So if somebody is detained for the protection of self or others because of their mental disorder, they have to actually be offered treatment. It doesn't mean that they have to accept the treatment. There are people in hospital who don't accept that they should be treated, but it is made available, and that's important from a human rights perspective, that people aren't just detained for the protection, but are also given treatment that would allow them to improve and then to be discharged again in the future. There's a number of people who have to be involved in making a decision to detain somebody, an approved mental health professional, which is usually a social worker, and 2 doctors. The nearest relative can object and has a voice to some extent, but there is no involvement of the court for somebody who hasn't offended. If somebody has offended, of course, they can be sent to hospital instead of prison, which is a hospital order, and you don't have to read all of those because the criteria are quite similar to non-offending people, except that the judge decides. What is important to point out here is, and this is very different from most other jurisdictions, is that the degree of criminal responsibility plays no role in the decision whether somebody is sent to a forensic hospital or not. So somebody can be detained in a forensic hospital regardless of whether they have criminal responsibility, whether they're insane or not. The decision is purely based on the fact that they have a mental disorder at the time when they are assessed and that they need treatment in hospital. So whether they or not at the time of the crime they were responsible doesn't make a difference. They can even be detained if at the time of the crime they were not mentally disordered, but they become mentally disordered later. They can still be sent to a forensic hospital. And they can also, under prisons, transfer, again this is different to other jurisdictions, they can be sent from prison after they've been sentenced to a prison sentence, and then they might develop a disorder 5 years later. They can then be sent from prison to a forensic hospital later on to be given treatment. And again, this is to some extent positive or an opportunity, because it means that people who are ill in prison are actually given treatment and are sent to hospital. On the other hand, they can then remain in hospital beyond the time of their sentence, so they could be given a 10-year prison sentence and then develop a mental disorder in year 10, and then they could be sent to a forensic hospital where the time of detention is not time limited, so they could be spending another 10 years afterwards in a forensic hospital. So that's the disadvantage, I guess, in terms of the time of detention. Consent to treatment is also an important issue to consider, and I would be interested to see how this is regulated in Egypt. In England, it is the case that for the first 3 months, treatment can be given, including medication mainly, and that does not require specific consent for somebody who is detained. But after 3 months, the person either has to consent specifically to the treatment, or they need a second opinion doctor coming from outside the treatment team and outside the specific hospital to agree the treatment plan. And there are certain more severe interventions, like surgical interventions, that always require consent and cannot be performed without the person's consent. Important again is also how somebody gets out, and that's, I guess, to some extent similar in that there are also opportunities for tribunals that meet initially after 6 months and then every 12 months. And those tribunals consist of a judge, an independent psychiatrist, and a lay member. And the patient can apply for a tribunal once a year. And if they don't apply, they get one every 3 years anyway. And these tribunals can then make a decision to discharge the person, except for some cases who have additional restrictions where the Ministry of Justice also has to agree for the discharge. And those patients coming from prison, when they still have a prison sentence, they can also later be sent back to prison. But again, there is no involvement of the sentencing court. It is done by this tribunal, by the hospital authorities and the Ministry of Justice, without a sentencing court. Just briefly to mention, again, you don't need to read all these criteria, just to mention we have community treatment orders as well, which allow patients to be treated against their will in the community after they've been in a hospital, and that allows certain conditions to be placed upon the patient to ensure that they continue receiving their treatment. For example, that they attend the clinic and take their medication and so forth, and if they don't comply with those conditions, they can be recalled to hospital. And most forensic patients would have those treatment orders for community treatment after discharge. I already mentioned that insanity and diminished responsibility, while it is available, does not play a role in the decision regarding as to whether somebody is admitted to hospital or not. So I'm not going to say much about these two. I'm moving on instead to the development of forensic services in the UK, which started really in 1863, where the first high secure hospital, Broadmoor Hospital, was opened, called Criminal Lunatic Asylum at the time. And this was followed by two other high secure hospitals, Runton Hospital and Ashworth Hospital. Runton Hospital is where I worked and where also Samar and some other collaborators came to visit. Yes, and then in 1975 there was a committee put together that found that these three high secure hospitals do not provide enough opportunities for slow rehabilitation back into the community, because they only provide high secure services, and the step from those high secure services back into the community is quite a large one. So it was decided at that point that medium secure services would also be required as a step down, and low secure services were also later developed. So these are the three high secure hospitals, and they have between 200 and 350 beds. Only Runton Hospital caters for women and for those who are deaf and for those who have learning disability. So any woman in England who needs a high secure hospital bed will be at Rompton Hospital. In addition to the high secure hospitals, as I said, we now have medium and low secure services as well. High secure services are very restrictive and they should be reserved for patients who present a grave and immediate danger. They are quite expensive, £800 per day. You can do a lot of work with that. Medium secure services are for those with a presentation of serious danger. Again, these terms are subject to discussion between different services when decisions are made as to where somebody needs to go. There are about 50 medium secure services in the country. In total, they have about 4,000 beds. And then there are also many low secure services and community services. In theory, this tiered system should allow the treatment to take place in the least restrictive setting. So if somebody doesn't need high secure care anymore, they can be moved to a medium secure setting. And we discussed that a bit with Samar and others, that that is a challenge here, that there's only these high secure services available. So providing lower secure services is definitely an advantage in terms of allowing people to step through the system to lower levels of security. On the other hand, given that in England those services are completely separate and not within the same provision, it can also cause serious delays when somebody has to wait for a medium secure bed to become available and then a low secure bed to become available, and there is a lot of inefficiency in the system when the different services argue amongst themselves which kind of level of security a particular patient might require. So it's not possibly the best way to do things. Better would be if you had different levels of security within the same institution. So these are just some figures showing forensic bed numbers. They're quite old now, but the general gist is still the same. So these are forensic bed numbers per 100,000, and the actual number itself is probably less meaningful than the comparison between different European countries, and you can see that England and Wales is somewhere in the middle in terms of how many forensic beds they provide. Again, this slide is quite old and it would look a bit like so and then leveling out if you were to continue it. But it does show that over the years the forensic beds have increased quite significantly. This is the case also in other countries, certainly is the case in England and Wales. At the same time, the bed numbers in high secure care have decreased. So what we're finding is we have less people in high secure settings, which is a good thing, but we have overall more patients generally in forensic settings. This goes along with closure of general psychiatric beds. Some people argue that there is a relationship between the two, but certainly there are many more medium secure beds, because they obviously only came about in the end of the 1970s, but even in the last years they have continued to grow. There's a huge number of patients actually detained in any kind of those forensic settings. In terms of the length of stay, about a third stay under 2 years. These wouldn't be the patients in high secure care. In high secure, the average length of stay is about 8 years. But these are figures for any security level combined. And then you have those who stay between 2 and 5, between 5 and 10 years. And then you have a proportion of about 20% of people who stay there for more than 10 years, and some for a very long time and potentially lifelong. And these are also the patients we are particularly interested in our project to see how one can move those on, how can decisions be made for teams to feel reassured that services can be provided or risk can be managed for those patients, so that they don't have to spend their whole life in a secure hospital. I'm not sure how well you can see this, but I will describe this. So the bit in the middle is a medium secure service. with about 60 beds. And what you can see on the left-hand side is where people come from, and on the right-hand side you can see where people go to. And the actual figures are actually not that important, but what is important to see is that the system in England as it is at the moment is actually quite complex. And that is another challenge because there's a lot of different people involved to make decisions and a lot of movement between services, which invariably slows things down and is not the most efficient way to do things. So if you look at this particular medium secure service, you can see that a proportion of people come from prison to the medium secure service. Some come from high secure care. So these are the actual patients you kind of want in this medium secure service. These are the ones who were successfully treated in a high secure service and then they go on to a medium secure service. So these are, you know, the ideal kind of pathway through the system. Then you have some who move from one medium secure service to the other. So this could be because they are moved to a service closer to home, or it could be that the particular medium secure service can't manage their needs or doesn't have the services they need. And then you have also quite a significant proportion who move from low secure to medium secure. So they were either directly admitted to low secure or they are rehabilitated to low secure service, but then increase their risk and then move back to a medium secure service. So you have in this medium secure service a whole mix of people who come from different services, and the way out is the same. Some move back to prison, some move up security to high secure, and down here is the kind of ideal pathway out to a low secure service or out to independent living or some sort of supported housing. But you can see that it's actually the minority who move down in this ideal pathway, and the others move, you know, back to prison or high secure services. So in terms of pathways, as I said, it's quite complex with a lot of movement back and forth and a lot of inefficiency. So just a few words about the treatment principles, and I know we want to have some other talks as well, so I'll be quick. So in terms of treatment principles, one important principle is that you provide security, quite obviously, but security is not just the structural security like the wall, but it's also about procedures, about policies you have, and it's also relational security. You develop a relationship with your patients that allows you to keep the patient safe, to know them well, to manage their risk, and to know when they are deteriorating and what kind of support you need to offer them. Then we place quite a lot of importance on evidence-based interventions, following the risk-need responsivity principles. So the higher the risk, the higher the need, the more services somebody should be getting. And you should also pay attention to responsivity issues, for example, motivation or any other factors that could get in the way of successful treatment. We try to be individualized in our approach to treatment and offer treatment in group as well as one-to-one settings. The ward milieu is quite important, has to be structured with clear boundaries and rules. Staff play an important part in providing a role model for pro-social problem-solving behavior, and it's important that staff deal with patients, particularly those with personality disorders, in a consistent way. It's also important to allow staff to develop, to train, to have supervision, to be able to reflect on the very demanding job they do. And we try to be patient-focused, focused on recovery, and actively involve the patient in their care. This is just an example from the enhanced personality disorder service I work in, where we provide treatment in different phases. So phase 1 would be preparation for change, so we're not assuming that somebody who comes from prison or from another service is automatically ready for treatment when they come to us. But we spend quite a lot of time on motivational work and on psychosocial education about personality disorder and about offending generally. And the next step would then be to address the issues related to the personality disorder itself, which is something that could otherwise get in the way of successful treatment of offense-related behaviors. So we provide a number of interventions addressing personality disorders before. Only then in the last phase we address the criminogenic factors in a number of treatment programs, sex offender treatment program, violence reduction program, substance misuse group. So this is just an example of how the treatment is delivered. So just very briefly, I won't go through all of this, but I think it's important to think about standards of care and how you can maintain them. In England there are a number of different measures. One is the Care Quality Commission. So this is a body that is independent of the providers and registers and inspects hospitals on a regular basis, partially unannounced, and they assess against certain standards to see whether they are met. So they inspect hospitals in quite a detailed way. So they come with dozens of inspectors for a couple of weeks to visit the hospital, and they look at safety, they look at effectiveness of treatment, and they look at whether the service provides a caring environment. They talk to patients. In private, they talk to staff, they inspect documentation, they look at whether the service is responsive to needs and whether the service is well led. And then they write reports, and they can potentially close down services. And they do close down services, or they can ask for services to improve certain areas, and then they are re-inspected. So it's quite an efficient way to monitor service provision. And there's also a voluntary quality network for forensic mental health, which is run by the Royal College of Psychiatrists. And this also looks at various areas: patient safety, experience, clinical effectiveness, and governance. This is voluntary, but all services actually also agree to participate in this quality network. And this network also does assessments, and they are done by multidisciplinary teams, and they include patients as well. So patients visit other services to be part of a team that inspects the quality of those services, and that is quite important as well. And these are just some examples of standards. They have quite detailed standards about physical security, procedural security, including how high the wall should be, whether it should be inspected, well lit, and so forth. So all these standards are assessed and reports are provided. And I'm just mentioning one other thing, which is commissioning for quality and innovation, which is a measure to financially incentivize good service provision. So this is a measure taken by the commissioners of services, and 2.5% of the contract, which doesn't sound a lot, but for quite expensive services it's money worth having. 2.5% of the money that is paid to services by the commissioners of the service is paid only if they achieve certain targets. And these targets change on an annual basis. So, for example, in one particular year it was physical health care. So it was necessary for all services to record the assessment of cardiometabolic parameters for all patients. And if they didn't achieve that, then they would be given 2.5% less money for their service, and then there's other targets the next year. So this is also an effective way to incentivize good treatment. And lastly, I want to say something about service user involvement, which is, as I said, important. So by this we mean primarily patients, but also carers. So firstly, there's a system of complaints, of course, where patients can complain, and they have the right for the complaints to be answered within 28 days, I think it is. There are patient councils in hospitals where patients contribute and raise issues they have found with their service. We try to promote involvement in patients' own care and involve patients lately also in interview panels. So when new doctors or psychologists or nurses are appointed, there is a patient on the appointment panel to help making the decisions as to who is appointed. We also involve patients in research in terms of setting the themes of the research, helping to interpret the research, and most recently as peer support workers supporting other forensic patients. And as I said, carers are also given the opportunity to contribute to service development. So just to summarize this, I've talked about some of the challenges in terms of the legal framework with the low age of criminal responsibility, the high imprisonment rates, the vague definitions for detentions, whether the role of the sentencing court, which is not present in England, is a challenge or not is I guess a matter of personal preference. The treatment of the patient against their will in the first 3 months, in my view, is problematic. The extended detention after prison sentence is also problematic, and the potential lifelong restrictions that brings with it. Some other European countries have actually started to restrict the length of forensic detention to match the equivalence of a prison sentence. So forensic detention can no longer be lifelong. But this is a minority of European countries. In terms of service organization, it is of concern that numbers of forensic patients are increasing. As I said, the distinction between the different levels of security is positive to some extent, but also causes bottlenecks to appear and the services to become quite inefficient. The services are therefore quite resource intensive. Evidence base, there is a reasonable evidence base, but it's not as good as in other areas of psychiatry, so we have to work harder to provide better evidence for the treatment, particularly of rare conditions like autism and so forth, what to do with those people who offend and have those disorders. Patient involvement is good, as I said, but we have to make sure that it's also meaningful, so it's not just done as a tokenistic way, but actually services do listen to what patients have to say. And we have quite a problem with negative views of the general population and the general press that reduces the chances of successful reintegration, unfortunately. So that's another thing I think we all need to work on in terms of stigma against our patients. And that's it.
Thank you, Professor Wong, very much for your comprehensive talk about forensic services and their challenges in the UK. I know that, of course, the time was very limited and your talk needed much more time. It's my pleasure to ask Professor Hisham Rami, Professor of Psychiatry at Shams University and previous Secretary General of Mental Health and Drug Addiction in the Ministry of Health. Professor Hisham Rami will be talking about Introduction to Forensic Psychiatry in Egypt, Challenges and Opportunities.
Can I comment until Professor Hisham starts? When we were in UK, just to continue on the UK topic, one of the very important things that was evident was patient involvement. Patient societies, I don't think, Dr. Hisham, do we have patient societies here in Egypt?
Yes.
Do we have? Okay, are they as active as they are in the UK?
Actually, now in Egypt, and this is thanks to a law which was issued in 2009, each mental health hospital in Egypt should have what is known as patient rights committee. And in it, there is a representation of the patients, of the families, and doctors and social workers and stuff like this. So now it's active. So, good evening everybody. I'm going to speak both in English and Arabic, so I think we need the translation for this. I'm really glad to be talking now. I think it's a big challenge to be talking after Professor Birgit. The UK has a very complex system. Egypt has a very simple system, so I don't know what I'm going to say. So in order to overcome this challenge, I'm going to review the Egyptian services historically. So from the pharaohs till now. If I put the video now, it will take only 2 slides. Okay. Okay, so it's introduction to forensic psychiatry in Egypt, challenges and opportunities, and this is what I do now. I speak both in English and Arabic. Egypt is one of the oldest countries or oldest civilizations in the world. We have one of the oldest mental health services in the world. In the papyri, this is one of them, which is the Edwin Smith papyrus, البردية بتاعت Edwin Smith، بتقول إن 2000 قبل الميلاد كان في فرعون اسمه امحطب وكان ليه وزير اسمه زوسر، ودول أول ناس عملوا سيستم للمنتال هيلث أشبه بالسيستم اللي لازال موجود حتى الآن. ولكن الفرق الحقيقي إن بدل ما إحنا عارفين دلوقتي إن المايند إز إن ذا برين، هم بيفرض ده المايند إز إن ذا هارت. هم كان فكرتهم إن القلب هو مصدر جميع المشاعر الحلوة والوحشة والأمراض النفسية والمشاعر العادية. وبدل المستشفيات Egypt up till now is a hospital-based mental health service. بدل المستشفيات they use the temples as hospitals. So this is one of the temples. It's called the Street Temple in Saqqara, which is very close to here. لو حد عاوز يزوره يعني ده في الجيزة. ده كان اسمه معبد النوم. One of the treatments used to treat psychiatric disorders at that time was induction of sleep. Using ايه الله اعلم ساعتها. غالبا بيشربوا بعض الخمور والبيرة، فرانا من اوائل الناس اللي اخترعوا البيرة في العالم يعني، وكانوا يستخدموها في علاج الامراض النفسية. اذا كان النظام مبني، وكان الدكاترة طبعا هم مين؟ الكهنة. مش كده لا؟ زي هامان والناس دي هم اللي كانوا بيعالجوا المرضى.
هو اول طبيب شرعي.
انا ما اعرفش، انا ده اللي عرفته. طب كويس. وكان the first forensic medicine was also invented in Egypt. So if you ever listen to an Egyptian doctor speaking about Egyptian medicine, of course what will be told is that the pharaohs created everything and they invented every specialty. ثم جاء العصر القبطي، the Coptic era. The same system persisted. نفس النظام، بس بدل المعابد اصبح هناك الايه؟ ما يطلق عليها دور العباده او الاديره اللي هي جمع دير يعني. وبدل الكهنه اصبح الرهبان والقسطة هم اللي بيقوموا بخدمه المرضى النفسيين. هل كان في فورنسيك سايكاتري ات ذات تايم؟ ده مش ريكورد، احنا ما نعرفش هل كان في طب نفسي شرعي ولا لا. ولكن من المعتقد ان كان يتم تطبيق التعاليم الدينيه اللي بتقول ان اللي عقله زي الطفل لا يعاقب، مش كده لا؟ فغالبا اللي كان مخهم ضعيف او مصابين بانسانيتي او الناس تراهم كانهم يحملون عقول الاطفال كانوا بيعتبروا مرضى نفسيين وبيعالجوا في هذه الاماكن. طبعا ده بيسموه ايه؟ the bright side of the picture. لان on the other hand كان طبعا في ايه؟ ناس مهمله ولا لا، وناس بتتفرج عليهم وناس بتعذبهم والكلام ده كله. ثم جاء التطور الحقيقي في الطب النفسي في مصر. العصر الاسلامي. دي صوره المستشفى لا زالت حتى الان موجوده في مصر. في القاهره القديمه. مستشفى قلاوون، مش عارف كلنا عارفينها ولا لا. اخر استخدام ليها كانت مستشفى رمض يعني. ولكن مستشفى قلاوون دي ايام السلطان نصر الدين قلاوون عملها، وكان السيرفيس ايه بقى؟ زي ما احنا بنعمل دلوقتي. سايكايتري ان ذا جنرال هوسبيتال. الطب النفسي كفرع من افرع الطب وفرع من افرع الامراض الباطنيه. فكانت هذه المستشفى منشاه كان اسمها دي ماريستان في هذا الوقت. وكان فيها يحجز المرضى اللي عندهم نزيف او اللي عندهم امراض ايا كان المرض، وكان هناك وحده او اسم صغير للامراض النفسيه. فكان المرضى النفسيين بيعالجوا زي ايه؟ زي المرضى العاديين. القوانين المطبقه في المسؤوليه الجنائيه او الكريمنال ريسبونسبيلتي ذاتها هي قوانين الشرع، مش كده لا؟ فالشريعه بتقول ان من لا يستطيع التمييز لا يعاقب، مش كده لا؟ فلو كان عنده ما يطلق عليه اضطراب سلوكي او جنون او مرض نفسي كان يحجز في هذا المكان. فكانت فكره رائعه. وكانوا من اوائل الناس اللي قالوا ان احنا هنعمل سيرفيس كوميونتي كير، اللي هي نظريه اللي ملوش اهل الحكومه اهل. فكان المجتمع كله هو اهله. وبدا يظهر ما يطلق عليه التكايه، مش عارف كلنا عارفين التكيه، مش كده لا؟ بترعى الغلابه والناس المشردين والمرضى النفسيين. فكان بدل ما كلهم بيحجزوا في مستشفى قلاوون كان بعضهم بيتم رعايته ككوميونتي سايكاتري. فده كان تقدم رهيب. ولكن زي اي شيء حلو في مصر بيبتدي جميل جدا، وان شاء الله المشروع ده ما يحصلوش كده يعني. الشيء بيبتدي جميل وفيري بروميسنج، مش كده لا؟ اللي حصل بعد شويه ايه؟ ان بالتدريج حصل اهمال للنظريه بتاعه البيماريستان بتاعه قلاوون، وبدا المرضى يهجرون هذا المستشفى. مين اللي ما هجرش المستشفى بقى؟ التانيين ليهم اهل بيجوا ياخدوهم. مين اللي مش حدش عاوزه؟ المرضى النفسيين. فانتهت المستشفى دي ما بقتش غير مكان محبوس فيه بعض المرضى النفسيين. وطبعا اهملوا وحصل تدهور رهيب حتى اتى هذا الرجل محمد علي باشا صاحب النهضه المصريه الكبرى. محمد علي صعبوا عليه الناس دول جدا. وكان في هذا الوقت اللي هو القرن ال19 كان بدا الفكر يبقى ايه؟ ان احنا هنعمل مصحات كبيره نحجز فيها المرضى النفسيين، ليس لحبسهم بعيدا عن المجتمع ولكن لتقديم رعايه جيده ليهم. ففعلا هو نقلهم من هذا المستشفى اللي تدهور حاله على مدار السنين ونقلهم لحته في بولاق، كانت ساعتها اسمها بولاق معناها بولق يعني البحيره الجميله، مكان جنب بحيره في خضره عشان يرعاهم. ولا زالت في هذا الوقت كنا تبع تقريبا لسه هنخرج من الاحتلال العثماني، كنا ولايه عثمانيه، فبتطبق علينا قوانين التركيه اللي هي اكشلي قوانين شرعيه، كانت المحاكم الشرعيه لو حد سمع عنها في تاريخ يعني المحاكم المصريه. وكان لو واحد ارتكب جريمه ووجدوا القاضي انه لا يستطيع التمييز كان يعتبر مريض نفسي يتحجز في هذا المكان. حته اسمها ورش ابو الجوخ، انا ما اعرفش هي فين دلوقتي يعني. حضرتك عارفاها؟ ورش ابو الجوخ في بولاد. ثم جاء بعديه بقى راجل الطف منه اللي هو قرر يجعل مصر قطعه من اوروبا، الخديوي اسماعيل. فخد الناس دي وقال لك لا ده المكان ده تدهور زي اي حاجه في الدنيا بتتدهور، وعمل لهم انا مش عارف بيسموها ايه بقى، وقف تراست، كويس ولا لا؟ لاحد السرايات التي تنتمي للعائله المالكه في هذا الوقت، العائله العلويه. هذه السرايا كان اسمها السرايا الحمراء، الكلام ده كان سنه 1880. عمل لهم وقف جميل على مشارف القاهره، خارج القاهره في المكان اللي كان حواليه، عارفين معسكرات الجيش الانجليزي؟ حاجه بقى طبعا انا ما حضرتهاش برضه. كان وقت كده كانها بره المدينه ولكن ايه؟ لا زالت قرب المدينه. وكان اسمها السرايا الحمراء. وللاسف الشديد حاجه نحس حصلت، حريقه كبيره دمرت هذه السرايا، ما فضلش منها غير الاسطبلات. وكانت هذه الاسطبلات مدهونه باللون الاصفر، فسميت على هذه السرايا الصفراء تيمنا. كانت حاجه حلوه ان الاصفر ما بيتحرقش، مش كده؟ لا، لان ده الحاجه الوحيده اللي نجت من الحريقه. فاكن ده ايه؟ علامه جيده ان ايه؟ مش هيحصل لهم ضرر بعد كده. ودي كانت طبعا بدايه مستشفى الايه؟ العباسيه. ده منظر المستشفى العباسيه في بدايه القرن العشرين. لو احنا شايفينها مستشفى جميله، مش كده؟ لا. وكان هو هذا المستشفى الوحيد. وكان حتى هذا الوقت لا زلنا بنطبق القوانين الشرعيه تبع الايه؟ المراسيم التركيه. فكان اي حد بيرتكب جريمه كان القانون اللي بيحكم هو ايه؟ التمييز، القدره على التمييز. وبدات بعديها بقى هنا ابتدى يظهر ايه؟ المحاكم الاهليه، مش كده؟ لا، وبعدين المحاكم المختلطه بعديها بشويه. وبدا يبقى تشريعات مصريه. من اوائل هذه التشريعات قانون العقوبات اللي كان تبع الايه؟ المحاكم الاهليه. وكان بيقول ان يعفى من المسؤوليه من كان فاقد التمييز وقت هذا وعقله مثل عقل الاطفال. ومن هنا بدات فكره شهاده ايه؟ معامله الاطفال. لو احنا بنشوف الافلام مش كده ده مع شهاده معامله الاطفال. دي بدات هذه النظريه في هذا الوقت. وقت العباسيه زي ما احنا شايفين جميله جدا يعني. يحكى والله اعلم تمام ان هذا هو تمريض مستشفى العباسيه في بدايات القرن العشرين. حاجه تدعو للشك طبعا، انا ما اعرفش جابوه منين يعني. المهم ده كان شكل المستشفى زي ما احنا شايفين جميل يعني. ثم جاء الخديوي عباس حلمي، كويس ولا لا؟ في بدايات القرن العشرين. وقال لك زي ما الخديوي اسماعيل عمل وقف للمرضى النفسيين، هنعمل وقف تاني للمرضى النفسيين. وقف على فدادين كبيره جدا على برضه بره القاهره اللي هو مستشفى الخنكه في القليوبيه. كان ساعتها بقى يعني هتبقى على حدود القاهره يعني من بره يعني. وعمل برضه ايه؟ وقف تاني. فبقى عندنا مستشفياتين كبار. ولا زال الناس اللي بيرتكبوا الجريمه لو رجاله ومصابين بمرض نفسي اقتضوا التمييز في هذا الوقت هيتحجزوا فين؟ في الخنكه. في الخنكه. وما عندناش احنا مستشفى اسمها مستشفى الطب النفسي الشرعي، لكن عندنا وحده للطب النفسي الشرعي، قسم من الاقسام مسخر الى ذلك. وظهر في هذا الوقت بقى بدا يطلق عليه الثوره التشريعيه في مصر. قوانين عماله تصدر. من اولها حاجه اسمها في العشرينات قانون سرايا المجازير. وقانون السرايا. وقانون التمرجيه. كان بينظم وبيضع قواعد ومسؤوليات عن الناس اللي بيقعوا هؤلاء المرضى داخل هذه المستشفيات الكبيره. وده كان تطور هايل ان بقى في نوع من حمايه حقوقهم بدل ما الدنيا ايه؟ بيتسابوا ويتنسوا. ولكن التطور الحقيقي حصل سنه 37 مع اول ظهور لقانون العقوبات المصري وقانون الاجراءات الجنائيه. اللي الغريب جدا ان من سنه 37 حتى الان لا زال نفس القانون هو اللي احنا بنطبقه. يعني قانون العقوبات في مصر او يطلق عليه البينال كود اتعمل سنه 1937. وقانون الاجراءات الجنائيه اتعمل برضه سنه 37. ده اسمه قانون 57 وده 58. واتحط فيه في ماده 62 لاول مره واضحه ما يطلق عليه ايه؟ مين هم اللي هيقفوا من المسؤوليه بيسموها كريمنال ريسبونسبيلتي لو مصابين بايه؟ جنون او آفة في العقل. وكان النص هقوله بعد شويه بسيط جدا. لا عقوبة على من كان فقد التمييز أو الإدراك نتيجة لإصابته بعاهة عقلية أو آفة في العقل، أو فقد أو كان يطلق عليه في غيبوبة عقلية نتيجة لتعاطيه مخدرات أو مسكرات على غير رغبته. الكلام ده اتكتب سنة كام؟ 37. وحتى الآن مع التطورات والتعديلات الرهيبة في القانون لا زالت هذه الروح هي اللي لا زالت سارية في المسؤولية الجنائية. أو لا عقاب على من يكون فاقد الشعور أو الاختيار في عمله وقت ارتكاب الفعل، إما لجنون أو عاهة في العقل، إما لغيبوبة ناشئة عن عقاقير مخدرة أيا كان نوعها إذا أخذها قهرا عنه أو غير علم منه بها. ده كان النص اللي سنة 37. هل يفرق عن النص اللي موجود دلوقتي؟ فروقات بسيطة مش قوي يعني، لكن هو ده النص اللي كان موجود ساعتها. ثم ظهر قانون تاني اسمه قانون 141 لسنة 44، بيسموه قانون حجز المرضى العقليين. لو احنا فكرنا في هذا الوقت كان عندنا مستشفى العباسية ومستشفى الخنكة، وأحد الكنائس عملت وقف عشان تعمل مستشفى ثانية، فبقى عندنا 3 مستشفيات في مصر، اللي هي مستشفى بيهمن دلوقتي. مستشفى بيهمن ليست مستشفى خاصة، هي مستشفى وقف من الكنيسة الإنجيلية للمرضى في مصر. مهم يعني مش مهم يعني، ده حاجات اقتصادية وتاريخية قانونية. فهم دول الثلاثة كانوا. فصدر قانون من مجلس النواب في هذا الوقت، أول قانون The First Mental Health Act in Egypt، كان اسمه The Law of 141 the year 1944، وكان بينظم وكان قانون جميل جدا. ولكن فلسفة القانون كانت ايه؟ ان اللي داخل مش طالع، يعني اللي هيدخل ما بيخرجش. فاحنا كنا بننظم دخولهم، ولكن القانون لا بينظم خروجهم. وقال ايه الحاجات لما يدخل يحصل له ايه، وكون لجنه اسمها لجنه المراقبه العقليه تفتش على المستشفيات دول زي الكوميشن اللي عندهم في انجلترا، وتشوف احوالهم ايه وتعمل عقوبات والكلام ده كله. ولكن رغم كل هذا الجمال دي، عشان عندي صور بس، كالعاده الشيء ابتدى جميل جدا منظم وقانوني، وعندنا 3 مستشفيات جمال، ثم حدث على مدار السنين كالعاده اهمال وتدهور. فدي بعض الصور بتورينا ان الناس كانت بتدخل وما بتخرجش، مش كده لا؟ فطبعا بيتنسوا جوه المستشفيات. طبعا صور مش جميله. حتى حدثت واقعه شهيره درجت بكليه الفورنسيك سايكايتري سنه 97. شايفين الراجل ابو دقن ده صورته من احد الجرايد يعني، مش جايبينها، هو مات الله يرحمه. هرب من مستشفى الخنكه. هرب بقى او خرج في اجازه، ده كلام ايه؟ يعني مش معروف ساعتها ايه اللي حصل. خرج راح ميدان التحرير اللي جنبنا يعني، وكان معاه مدفع رشاش، وطلع اتوبيس كان فيه سواح المان، وقتل كل سواح الالمان اللي في الاتوبيس. واكتشفت السلطات في هذا الوقت ان الراجل ده كان محبوس في مستشفى الخنكه في جريمه اخرى، عشان تم اعفائه من الريسبونسبيلتي نتيجه لاصابته بايه؟ عاهه في العقل. فده كان فورنسيك بيشنت، خرج يقال في اجازه بورقه او خرج الله اعلم، قتل الناس. رغم انها هذه فاجعه في مصر، لو حد فاكرها مش عارف كلنا فاكرينها ولا، كانت حادثه رهيبه، ولكن نشأ منها حاجه مفيده جدا للفورنسيك سايكايتري اند المنتال هيلث سيرفيسز في مصر. بعديها على طول اصدر رئيس الجمهوريه قرارا اسمه القرار الجمهوري سنه كام؟ بتاريخ 3 سبتمبر سنه 97، قرار رقم 231، بان المستشفيات الكبيره اللي فيهم فورنسيك سيرفيسز، خنكه، العباسيه والمعموره ومصر، يعني 5 مستشفيات يتم ضمهم. انتوا عارفين السيستم في مصر فيه مستشفيات تبع المحليات ومستشفيات تبع الديوان، يتم ضمهم تحت الاشراف المباشر لوزير الصحه، وتشكيل لجان لاعاده هيكله الفورنسيك سيرفيس في مصر. مش عشان طبعا حبا في المرضى، ولكن عشان طبعا تهديد للامن القومي. الراجل هرب قتل السواح. ومن هنا بدا النهضه الحقيقيه للخدمات بتاعه الصحه النفسيه في مصر والفورنسيك سيرفيس في مصر للامانه الشديده. القرار ده طبعا ضم المستشفيات دي اللي احنا شايفينها، كانوا 5 مستشفيات بقوا تحت الامر المباشر لوزير الصحه. كان وزير الصحه في هذا الوقت برضه استاذ من عين شمس، زي ما احنا دلوقتي الدكتور احمد عماد هو وزير الصحه، كان ايامها الدكتور اسماعيل سلام. وكان رجلا برغم اي كلام ممكن يتقال عليه انا ماليش دعوه، كان رجلا عبقريا ورجلا نشيطا جدا، وجاب مشروع مخصوص لتطوير الصحه النفسيه في مصر. بعض الناس اللي هنا ممكن يكونوا حضروا هذا المشروع، كان اسمه المشروع الفنلندي للنهضه لتطوير الصحه النفسيه في مصر. منه جزء كان لتطوير الفورنسيك سيرفيس، ومنه جزء لتطوير المنتال هيلث سيرفيسز عامه. وبدا التطوير منذ ذلك الحين، واصبح عندنا كفورنسيك سيرفيس المهم يعني تشكلت حاجه اسمها الامانه العامه للصحه النفسيه اللي هي بترأسها الدكتوره منى دلوقتي. كويس ولا لا؟ هذه الامانه هي المين بروفايدر اوف mental health service في مصر عامه وذا اونلي بروفايدر اوف فورنسيك سايكاتريك سيرفيس في مصر. لا يوجد اي حد تاني بيقدم هذه الخدمه في مصر غير الدكتوره منى، فنشوف هيحصل ايه. فربنا معاها يعني. مفيش اي حد في مصر بيقدم هذه الخدمه خالص. ده بقى قد ايه الامانه دي حاجه جميله جدا. تبعها دلوقتي حوالي 19 20 مستشفى، وفي كذا مستشفى هتفتحهم دكتوره منى، يعني الدنيا كبرت جدا. ورغم هذا التطور لكن فضل الفورنسيك زي ما هو. عباسيه والخنكه زودوا ان بقى في وحده في الاسكندريه في المعموره، ولكن ليس لتقديم خدمات الفورنسيك سيرفيس، وحده للتقييم فقط وليس لحجز المرضى وتاهيلهم. يعني ده قد ايه الدنيا بقت جميله وانتشرت في كل محافظات مصر. الوضع الحالي هو ايه في مصر بقى؟ عندنا اول حاجه الكريمنال ريسبونسبيلتي، مش كده؟ لا طبعا ده فيلم مشهور جدا، ده جاك نيكلسون، فيلم ذا شاينينج، مش كده؟ لا كان سايكوتيك وعمال يقتل الناس كلها. ده الصوره بتاعتنا طبعا. تاثرا بما يطلق عليه المكنوت مرور في انجلترا، و عارفين الراجل ده طبعا، مش كده؟ عارفين الجريمه دي ولا لا؟ دي جريمه شهيره جدا. ده الرئيس رونالد ريجن، وده الراجل اللي ضرب مسدس، مش كده؟ لا. ودي الممثله اللي هو ضربه عشانها، كان اسمها جودي فوستر. كان بيحبها، كان في فيلم شهير قوي اسمه تاكسي ايامها، فالراجل اتفرج على الفيلم وعجب بيها جدا، فجاله اصوات بتقول له ايه؟ عشان هي تحبك روح اضرب مين؟ ريجن. المهم طلع منها ساعتها فيرد الثاني غير المكنوت بتاع انجلترا، هو جيلتي بات منتالي ايل، مش كده؟ لا. فالمشرع المصري تاثرا بالاثنين دول عمل الايه؟ الماده اللي احنا ماشيين عليها دلوقتي، اللي هي اخر تعديل ليها كان سنه 2009، ماده 62 من قانون العقوبات المصري. طب متاثره بالحكمين دول، بتقول ايه بقى؟ بعد ما كان لا يعاقب والكلام ده اللي قبل كده حصل مليون تعديل في الستينات والسبعينات، لكن ده اخر تعديل. لا يساءل جنائيا الشخص الذي يعاني وقت ارتكاب الجريمه من اضطراب نفسي او عقلي. اول مره يدخلوا ايه بدل عاهه عقليه او آفة كلمه اضطراب نفسي، مش كده؟ او عقلي وقت ارتكاب الجريمه افقده الادراك او الاختيار، او الذي يعاني من غيبوبه، ده نفس الكلام القديم، ناشئه عن عقاقير مخدره ايا كان نوعها اذا اخذها قهرا عنه او على غير علم منه بها، ويظل مسؤول. دي بقى الجديده بتاعت جيلتي بات منتالي ايل. ويظل مسؤولا جنائيا الشخص الذي يعاني وقت ارتكاب الجريمه من اضطراب نفسي او عقلي، يعني نفس الكلام اللي مكتوب فوق، ولكن بدل ما هو افقده ادى الى ايه؟ انقاذ ادراكه او اختياره، فده هيبقى جيلتي بات منتالي ايل، مش كده؟ لا. يعني الثاني هيبقى نوت جيلتي فور ريزون اوف انسانيتي، لكن ده ايه؟ جيلتي بات منتالي ايل. وتاخذ المحكمه في اعتبارها هذا الظرف اكنه ظرف مخفف عند تحديد مده العقوبه. سهله كده ولا لا؟ فاحنا تاثرنا بالايه؟ بالنظريتين. وكمان طلع يعني في قانون الاجراءات الجنائيه حاجه لها علاقه بهل البيشنت او الشخص قادر انه يتحاكم ولا مش قادر انه يتحاكم، يعني غير انه مسؤول جنائيا ولا لا، اللي مطلق عليها competency to stand trial. في القانون المصري قانون الماده 339 من قانون الاجراءات الجنائيه اخر برضو يعني نص ليها بتقول ايه؟ اذا ثبت ان المتهم غير قادر على الدفاع عن نفسه بسبب اضطراب عقلي طرأ بعد وقوع الجريمه، يعني هو ما كانش عيان ساعتها او الجريمه ما كانتش متاثره بالمرض النفسي بتاعه، يوقف رفع الدعوه حتى يعود اليه رشده، ويجوز في هذه الحاله لقاضي التحقيق او للقاضي الجزئي كطلب للنيابه العامه او المحكمه المنظور امامها الدعوه اذا كانت الواقعه جنائيه او دونها عقوبتها الحبس، اصدار الامر بحجز المتهم في احد الاماكن او المحال المعده للامراض العقليه الى ان يتحدد اخلاء سجله. يعني عندنا طريقتين ممكن نحجز بيهم المرضى، مش كده؟ واحده ليها علاقه بالكريمنال ريسبونسبيلتي حكم من القاضي، وواحده ان هو مش قادر اصلا يتحاكم، فهنا بقى بيقعد فتره مؤقته وبعدين يتحاكم تاني، كويس ولا لا؟ يعني يعود اليه رشده ويرجع للمحكمه تاني. فالحقيقه القوانين المصريه جميله يعني. طب هل القانون نظم الناس دي هتخرج ازاي بعد كده ولا لا؟ الحقيقه القانون نظمها وقال الاتي، ودي ماده بقى محتاجه تطوير تشريعي الحقيقه. بتقول ايه بقى؟ الماده 342 من قانون الاجراءات الجنائيه، يتم حجز المتهم اللي احنا قلنا عليه في احد منشآت الصحه النفسيه الحكوميه اللي هي المعاقبه عليها بالحبس الى ان تأمر النيابه بالافراج عنه، يعني صاحب القرار في خروج هؤلاء المرضى من اماكن حجزهم ليس الاطباء، كويس ولا لا؟ تأمر النيابه بالافراج عنه بعد التثبت، ودي الكلمه اللي صعبه جدا، التثبت، من انه قد عاد اليه رشده. طبعا مش يعني النظام انا هقول دلوقتي حالا ازاي اتثبت ان انسان عاد عليه رشده؟ صعبه جدا، مش فاهم ان انا اقول الراجل ده عاد اليه رشده، صعبه ومليئه بالايه؟ تقييمات واراء وسبجكتيف وبدل ما هو اوبجكتيف قوي، فده بيعطل خروج الناس كتير. طب ايه السيرفيس في مصر متقسمه ازاي؟ عندنا الاول عندنا ما يطلق عليه فورنسيك سايكايتري يونتس، وحدات الطب النفسي الشرعي، وهم عشان يعني ما تحسوش ان الموضوع كبير قوي، هم 3 حتت. عندنا العباسيه فيها خدمه التقييم، يعني بيحول اليها المتهم قبل ما يتحاكم عشان يتعمل له تقرير، وهذا التقرير الحقيقه دلوقتي حصل تطور فيه رهيب جدا، واعتقد انه دلوقتي بقى بيتعمل بطريقه فنيه وفيها اخلاقيات عاليه جدا. لجنه ثلاثيه مشكله في كذا لجنه، يعني هم دلوقتي 13 اعتقد لجنه، كل لجنه فيهم 3. غالبا اللجنه دي بتضم 3 من ما يطلق عليهم خبراء في مجال الطب النفسي. غالبا بيبقى احد اعضائهم استاذ من احد الجامعات، ومعاه استشاري من احد مستشفيات الصحه النفسيه، ومعاه ما يطلق عليه استشاري تاني او حد على وش استشاري، وهيبقى ايه يعني كده. هذه اللجنه هي اللي بتقيم وتقول الكريمنال ريسبونسبيلتي، وطبعا زي ما حضراتكم عارفين رايها في الاخر ايه؟ ليس ملزما للقاضي، ولكن رايها استشاري. في معظم الاحوال اللي بصراحه القاضي بياخد دي يعني، لكن مش رايها ملزم. والدنيا دلوقتي والحقيقه حصل تطوير رهيب على مدار سنوات طويله، ان فعلا بقت هذه اللجان بتعمل التقييم بطريقه جميله، التقارير بقت تقارير مقننه علميه، وبقت الجزء ده من الطب الشرعي بقى كويس جدا. وهو موجود في حتتين بس، يا في العباسيه يا في اسكندريه في المعموره. يعني لو واحد في اسوان قرر القاضي انه عاوز له تقييم بيتبعت لغايه القاهره، فده احد الديفيشنسيز في السيرفيس الرهيبه يعني. العباسيه والخنكه فيهم كمان حجز بقى المرضى بعد ما القاضي بيحكم عليهم، اللي المفروض يحصل لهم تاهيل وبسرعه عشان يعودوا الى الايه؟ المجتمع. طبعا العوده الى المجتمع شيء صعب جدا. واليونتس دي whether for assessment او for rehabilitation and treatment are high secure units ومحميه بضباط بوليس. يعني لو حد راح شاف وعساكر والدنيا يعني ايه، ما عندناش احنا ولا ميديم سكيور ولا لو سكيور. ده اول حاجه عندنا. عندنا كوميتيز او لجان فور اسسمنت اوف ريسبونسبيلتي اللي احنا قلنا عليهم. عندنا لجان فور اسسمنت فور فيتنس تو ستاند ترايل، وعندنا لجنه مكونه اسمها كوميتي فور اسسمنت فور اليجيبيليتي اوف ديسشارج. دي احد مشاكل الطب النفسي الشرعي في مصر. هذه اللجنه ما هو تشكيلها؟ تشكيلها غير الاطباء النفسيين بيضم ممثل لوزاره التضامن الاجتماعي، ممثل لوزاره الداخليه وده حاجه يعني مشكله كبيره، وممثل للايه؟ لوزاره العدل اللي هو غالبا رئيس المكتب الفني للنائب العام. ارائهم مختلفه تماما عن رؤيتنا كاطباء لامتى الراجل يخرج. عندهم ما يطلق عليه ايه؟ معايير ثانيه، مش كده؟ يهمهم قوي جسامه الجريمه، مش كده؟ احتماليه انها الجريمه تتعمل ولا لا، بغض النظر الراجل اتحسن ولا ما اتحسنش، او العيانه اتحسنت ولا ما اتحسنتش. ايه التشالنجز والاوبورتيونيتيز اللي عندنا؟ اهي دي الخدمات اللي عندنا، كويس ولا لا؟ عندنا دلوقتي خدمات التقييم بقت حلوه فعلا، خدمات العلاجيه والتاهيليه محتاجه تطوير لغايه دلوقتي، واعتقد الدكتور حاتم قاعد معانا وهو مسؤول عن هذا الملف، كويس ولا لا؟ ان ازاي تبقى الدنيا متطوره. يعني في كام عيان، في كام متهم محجوز دلوقتي في الخنكه؟ 655. بقى عندنا 655 واحد ادميتد للخنكه، رجال يعني دول رجاله محجوزين على هذه الهاي سكيور يونت في الخنكه. والعباسيه اللي هم السيدات 32 الحمد لله. في الستات جرايمهم واضح انها اقل، بس الستات 32 بس، او يعني او اذكياء من الحمد لله يعني. لكن احنا شايفين الرقم قد ايه؟ شايفين الرقم قد ايه؟ هل الناس دي نسبه الخروج قد ايه يا دكتور حاتم دلوقتي؟
نسبه الخروج يا فندم كده زي حضرتك قلت كده، لان النيابه ووزاره العدل
تدخل اللي هي الجهات الاخرى
النيابه ووزاره العدل بيبقى ليهم ستاندردز في القرار
مختلف عن خالص رؤيه الطب.
ليها علاقه بقى بالبوليتيكال اسبيكتس والجريمه والفتنه الطائفيه وحاجات.
فعندنا مشكله. عندنا مشكله الاساسيه الحقيقيه رقم واحد، the system is very centralized. هل معقول دوله فيها 27 محافظه ويبلغ مساحتها 1,000,000 متر مربع ما يبقاش فيها غير هم دول السنترز بتوع الفورنسيك سايكاتري؟ هل ده معقول؟ هل it makes sense؟ ولكن عشان نشر الخدمه محتاجين كوادر مؤهله، مش كده؟ لا، واقناع وزاره العدل ووزاره الداخليه بانهم يساهموا معانا في انشاء هذه الوحدات، لان هم اللي بيبقوا ايه؟ بيشوفوا على امنها والدخول والخروج والكلام ده. طبعا ده مشكله كبيره، مش كده؟ لا، فده تشالنج. الاوبورتيونيتي ان احنا دلوقتي في مرحله تغيير، مش كده؟ لا، الصحه بتتغير في مصر. احنا عارفين سمعنا عن حاجه اسمها قانون التامين الصحي الاجتماعي، مش كده؟ لا، ده هيبقى مصر هتبقى شبيهه بانجلترا عشان نكون امنا يعني، هو كوبي بيست من انجلترا. وهيبقى عندنا ما يطلق عليه الجنرال براكتيشنر او الفاميلي فيزيشن، وهتبقى كل حاجه متقسمه جيوغرافيكال وكاتشمنت ارياز. فالمنطقي يبقى عندنا ايه؟ سايكايتريك سيرفيسز بنفس المنظومه، والفورنسيك يبقى جزء منها، مش كده ولا لا؟ فالسنتراليزيشن ده رهيب، حاجه مشكله كبيره يعني، لازم دي سنتراليزيشن اوف سيرفيسز. رقم 2 احنا وي اونلي هاف هاي سكيور يونتس، لا عندنا ميديوم سكيور يونتس ولا عندنا لو سكيور يونتس. بغض النظر عن الليفل اوف ريسك او الدينجرسنس بتاعه الاوفندر بيتحط في نفس المكان، مش كده ولا لا؟ ولا امل انه ينتقل لمكان اخر، يا هيخرج على بيته يا قاعد في نفس الايه؟ المكان، مفيش ليفل، مش كده ولا لا؟ الحاجه الثانيه we have no forensic community services. يعني السؤال اللي دايما بيتسال، الراجل ده او الست دي خرجت مين هيتابعها انها ما ترجعش تنتكس تاني وتعمل نفس الجريمه؟ فاحنا we need community forensic services. وده طبعا اللي هو يعني زمان كده كنت بنتكلم فيه الدكتور حاتم، والدكتور حاتم ريحني جدا، قال لي انا هعمل لك كل حاجه، وفضلنا مبتسمين مع بعض وما اعرفش حصل لي بعد كده، بس ان شاء الله يعني ان شاء الله تتكون يعني ان شاء الله، لان ده هيغير وجه الموضوع خالص. الحاجه الثانيه هي هل في فورمال تريننج في الفورنسيك سايكاتري؟ في تريننج، يعني الامانه العامه للصحه النفسيه بتعمل تريننج للناس على الموضوع، في حاجه اسمها المجلس القومي للصحه النفسيه بيعمل للناس تريننج هاو تو رايت ريبورت، كويس ولا لا؟ لكن هل بندرب التمريض والاخصائيين الاجتماعيين على تاهيل المرضى؟ على فورمال اسسمنت اوف ريسك زي مثلا زي الاتش سي ار؟ ما بنعملش كده، مش كده لا؟ احنا بنعتمد يعني بامانه شديده على خبره الناس، يعني ممرض قديم، مش كده لا؟ ايه رايك في محمد؟ يقول لك لا ده احسن دلوقتي، ده الخطر بتاعه قل. ما عندناش دوكيومنتيشن، مش كده لا؟ واعتقد ان احنا لما هنبقى مدربين على ذلك ده هيساعدنا جدا لما نيجي نتكلم مع بتوع النيابه، مش كده لا؟ عندنا سكيلز وسكورز، الناس متدربه على الموضوع ده، وهي حبذا كمان، وده المفروض الدكتور حاتم بيعمله برضه، اللي هو برامج تاهيليه، مش كده يبقى في ريهابيليتيشن حقيقي عشان الناس دي تخرج. لان اعتقد ان في الريسيرش اللي عاملاه اللايف بروجكت ده هيطلع نسبه يعني متوسط وعاد الناس جوه هذه المستشفيات عشرات السنين مثالي كده يعني. فاحنا محتاجين نغير هذا السيستم. Decentralization, different levels of secure units, community forensic service, formal training، يبقى في higher specialist training للناس اللي عاوزين يتخصصوا في الفورنسيك سايكايتري، ويبقى عندنا formal risk assessment skills. اعتقد لو عملنا ده هيبقى انتقلنا لمرحله التشالنجز للاوبورتيونيتيز وديفلوبمنت اوف a very good service. Thank you very much على معاكم.
شكرا للاستاذ دكتور هشام رامي. زي ما اتفقنا هيبقى الاسئله all questions are going to be at the end of our session. We come now to our final speaker before our panel discussion. Professor Kevin Douglas will be talking about the HCR-20 V3 versus uses and accessibility. And as I understand, Professor Douglas has been conducting a 2-day training course for training of the trainers, and the HCR-20 has been translated into Arabic by a team of Egyptian psychiatrists and back translated, and is being currently once again back translated to English. So I hope that you are satisfied with what is being done, and at the same time we would be very keen to listen to your presentation on the HCR-20.
Great, thank you very much, and thank you so much for coming. I'm very happy to be here. I'd like to extend my appreciation to Dr. Samar for inviting me, and also to Professor Birgit from the LIFE Project. And I've been so pleased by the warm hospitality of the Egyptian people. So it's been lovely to be here. I have indeed seen some antiquities, the pyramids, of course, the Sphinx. I sat on a camel.
That's the real challenge.
The real challenge. I didn't fall off on the way down. Yeah, that was good. And I think my favorite cultural experience here so far has been experiencing the traffic in Cairo. That's been quite a thrill. So I'd like to talk to you about structured assessment of risk for violence and the management of violence risk. This is a topic I've cared about for a long time and have been working on for close to 25 years. So I'll talk about common legal and clinical applications. I realize very much that we're in a forensic psychiatric setting right now. We're talking about forensic psychiatry, but risk assessment is relevant in other settings as well. A brief history of the field of risk assessment, the goals of risk assessment, what are we trying to accomplish. I'll introduce very briefly this model of violence risk assessment called structured professional judgment. And one exemplar of that model is the HCR-20, which stands for Historical Clinical Risk Management, and there's 20 risk factors. Historical, past risk factors, clinical, more current, recent risk factors, and the risk management scale has to do with future concerns. I'll talk briefly about research support for the HCR-20. There's a lot of talk about research and the LIFE project and the work that will come out of that, so I'll give a little nutshell summary of the research support for the HCR-20 and relevance in Egypt and beyond in the Arabic-speaking world. So common applications, you can see forensic there, the second on the left. This is also used by private practitioners in different countries in the world who get, say, hired by the courts or lawyers to inform the court. It's used in corrections, so a lot of prison services in different parts of the world. It's used in general psychiatry as well, civil psychiatric, general mental health. The police also use it in different parts of the world to help manage cases. So those are some of the settings in which it's used, and then on the right-hand side you can see what it's used for. So it's often used to manage risk over time, to make admission decisions if somebody's coming into a forensic hospital, for example, to monitor them while they're in the forensic hospital, to plan for discharge, and then for community functioning and to monitor them in the community after discharge. So a brief history of risk assessment. Johnny Backstrom and Henry Stedman. Johnny Backstrom was a mentally disordered offender in the United States. Henry Stedman, a sociologist. Johnny Backstrom was subject to a law in the US, in New York State at the time, called the Dangerous Mentally Disordered Accused. If you had a mental disorder and you were convicted of certain violent crimes, after your prison sentence, you could be declared a dangerous mentally disordered accused because you were considered to be high risk for violence, and you can be detained indeterminately for a length, unspecified length. Johnny Backstrom didn't like that, so he appealed all the way up to the US Supreme Court and said, my rights are being violated on the grounds of mental disorder. You can't do this to me just because I have a mental disorder. So he won, and the US Supreme Court said Johnny Backstrom and 966 other people in his situation need to be discharged or transferred to less secure facilities like civil psychiatric facilities. So all of these people had been predicted to be violent. That's why they were detained. Hank Stedman, who's still active in the field 50 years later, followed these patients up. 7% had another violent conviction. 7% out of 967 people. So vast over-prediction, inaccurate prediction of violence. John Monahan summarized in 1981 5 different studies. That's all there really was in 1981 on risk assessment, and declared that we were inaccurate 2 out of 3 times. We made some statement of future violence risk. So the early research was not promising. There were a handful of risk assessment instruments in the early 1990s. I would argue today there's too many. People keep developing new instruments. There's hundreds of risk assessment instruments. Many of these are what we call homegrown. They're used, say, just in the Ohio Department of Corrections or the Florida Department of Corrections. The HCR-20 was first published in 1995, but in 1998 there was the first publication on it. So in just under 20 years, you'll see where the state of the research is now. There's over 300 disseminations of publications, dissertations, and so forth. I'd say there's about 450 studies in general of structured professional judgment, and probably about 800, maybe even to 1,000 studies on risk assessment more broadly. What do we want to do with risk assessment? What is the purpose and the point? We need to identify who is higher and who is lower risk. That's one of the core elements to it. Who poses a greater risk if they were, say, discharged from one of your forensic hospitals into the community? We want to prevent violence. We always say we want to for the patients, we want to help them be happy and healthy, or move them along a path toward being happier and healthier, and that includes not hurting other people. Risk assessment system should also include an emphasis on accountability for us. So it's important that our decisions are transparent, fair, and reviewable, so that a judge or a court can see how we reached our decision. That's fair for patients. We want to protect patients' rights so that they're not detained arbitrarily. But we also, and this may not be as much of an issue in Egypt, but in some parts of the world, like the United States, there's a lot of lawyers, and they like to sue people, including psychiatrists. So we want a system that is evidence-based, because that helps protect our own liability. So the end goal is the prevention of violence, hopefully no violence, but at least the mitigation of violence. To get there, we need to understand why people are violent, and we need to manage and treat. The first step, though, is to try to identify and forecast who is higher and lower risk, and upon what grounds. There's been over the years a few different methods of risk assessment, so general approaches. The first, I'd say, is one that's completely discretionary. There's no real guidance. Some people in the field have called this unstructured clinical judgment. Of course, clinical judgment is a valuable and positive necessity in a risk assessment, but within some level of structure, it can be very helpful. Structured professional judgment, I would say, has allows for an optimal amount of discretion. It's semi-structured, so the professional can still exercise some judgment. Actuarial approaches, I would argue, give no discretion to the profession. They kind of prejudge what the important risk factors will be, kind of regardless of the case specifics. So they're over-structured. Structured professional judgment relies on guidelines to help structure your judgments about violence risk. It guides prevention through planning, reflects best practice, it specifies basic risk factors, which we'll get to, but it doesn't restrict your scope. So if there's other risk factors that you think are important in a given case, you can consider those. There's no algorithms used, so you don't have to do calculations, mathematical calculations to come up with a risk estimate, but there definitely are coding rules and structure around how to come to decisions. Finally, it's intended to be good for monitoring change. This is really important. Is somebody getting worse? Do we need to change our risk management plan? Are they doing better so we can maybe reduce the intensity of supervision? We really value reliability and validity. There's been a lot of research on this approach. Structured professional judgment, as I mentioned, can be applied broadly in different fields: forensic, general psychiatry, prison. It's intended to be a comprehensive risk assessment to get a good, thorough understanding of why somebody poses a risk for violence. Informs management, treatment, and prevention. It's semi-structured, optimally structured, so it tries to draw on the strengths of both clinical judgment approaches, pure clinical judgment approaches, as well as some of the benefits of an actuarial approach, such as transparency and structure. It's evidence-based, and it's geared toward standardizing evaluations, recognizing that there are variations in the challenges based on different settings. So you may have, in some settings, more time to do an evaluation, in other settings, less time. You might be working in the community, you might be working within a hospital. The HCR-20 itself is a 130-page long professional manual. The translators were really happy to find that out, 130 pages. It also comes with rating and worksheets. So there's structured worksheets for you to be recording which risk factors are present, and your ideas about management and so forth. It's geared to answer three basic questions. Why has the person done what he or she has done in terms of violence? What are you worried that this person might do in the future? And what are you going to do about it to try to prevent that harm? Three basic questions. Those questions we then, in the manual, help the mental health professionals break down those questions into various steps. Okay? These are the steps. Question 1, why has the person done what they've done? Is dealt with in these first 4 steps through gathering relevant information, rating the presence of risk factors, rating the relevance of risk factors, and developing a formulation. A formulation is the integration of risk factors into a meaningful individual theory of violence for a given person. It helps answer that question, why has the person done what they've done? Is it because of difficulties in coping and stress, which leads to substance use problems, conflict at work, conflict with relationships? Is it because of paranoid delusions? Is it because somebody is psychopathic and so they lack empathy? It's the explanation of why someone has done what they've done. The second question, what are you worried they might do in the future? If they're discharged, what are you worried they might do? This is dealt with steps 5 and 7. What's the risk level? Is it low, moderate, or high? And what are the scenarios of violence? A scenario of violence is a possible way that violence might manifest. So of course the person could always do what they've done in the past. Somebody's committed a homicide while they're psychotic. Somebody's committed a sexual offense. We always have to consider what we call a repeat scenario. But they may do something somewhat different. They may offend against a different person for different reasons. Their violence could get worse. So we need to also consider what we call twist scenarios and worst case scenarios. The last question, what are we going to do about it? That's addressed through the development of case management plans. So understanding the formulation, the risk factors, this leads into what we call the scenario planning. And that is meant to inform case management. How do we monitor people? What warning signs should we be looking for? What's the best treatment to line up with the risk factors they have? What level of supervision should there be? And is there anything that we can do to help potential victims through victim safety planning? I'm not going to talk about these in detail, but these are the risk factors on the HCR-20. So on the historical scale, at any point in a person's life, have they had a history of violence? Have they had other antisocial behavior? Have they had relationship problems, employment problems, substance use problems? Do they have a major mental disorder? So in your setting, probably this one would always be answered yes, right? But this instrument can actually be used in settings where people might not have a mental disorder. Prisons, for example. Do they have a personality disorder like psychopathy? Have they been subjected to traumatic experiences? Do they have violent attitudes that support and condone the use of violence? And have they shown poor treatment or supervision response or compliance? So we look at those across the person's lifespan. Then we focus our attention to how have they been doing for the last 6 or 12 months? What kind of treatment progress are they making? Do they have problems with insight? So self-awareness into their mental disorder, proneness to violence. Do they have violent ideation? Have they been thinking recently about hurting people or threatening to hurt people? Active symptoms of major mental disorder, do they have emotional or behavioral instability? And do they have a current treatment or supervision response problem? So we focus historically, then we take a look at how they're doing recently, and then we shift our attention to how do we think they're going to do in the future? So if they're discharged, what will life look like for them in the next 6 to 12 months in terms of, do they have any problems with professional services and plans? Do they have good plans in place that address the risk factors that they have? Is their living situation stable or unstable? Are they going to be living with people they don't get along with? What kind of activities are they going to fill their day with? Productive ones? Unproductive ones? Do they have personal support from friends and family? What's their treatment or supervision response going to be like in the future? And then how are they going to deal with stress? What are their coping abilities? So we have operational definitions for each of these risk factors, the worksheets, you can record your responses to them, the evidence for them. Then we encourage people to think, well, of the risk factors that they have, which ones are most relevant for understanding their violence? You could have 2 people, both of whom have substance use problems. For one person, it could have nothing to do with why they're violent. For the other person, it could be everything. Every time that they use substances, they're violent against a partner, or they're violent against their family. For other people, they might use substances and just pass out on the couch. So I want to talk, excuse me, talk a little bit about some of the research, given the research themes within this evening's presentations and the purpose of the presentations. And there'll be some researchers in the room, I realize. There's also clinicians and people who do both, and administrators. I always feel a duty to tell people a little bit about the research, because these are high stakes decisions, right? And using an instrument like the HCR-20 or for any type of risk assessment measure, it's important for you to know what is the degree of evaluation of it. First published in 1995, version 1 in 1995. The first 4 studies, they weren't yet published, but we did a handful of studies in 1996. We made a few revisions based on that, and version 2 was published in 1997. First published article was 1998, but then there have been hundreds more since then. People around the world, I think we're all facing the same struggles. How do we evaluate risk for violence? In Canada, in 1995, that came just a few years after a change in the law. So we've heard about changes in the law here in Egypt to try to formalize the release procedures, right? It was the same situation happening in Canada in the early 1990s. It used to be that a forensic patient could be held, and the way the law read, of course we have British influence in our laws, it said, until the pleasure of the Lieutenant Governor is known. Until the pleasure of the Lieutenant Governor is known. Meaning there are no criteria for discharge. It's whenever the lawyers and the government say, well, this person can get out now. 1992, that was changed. And there's now a big piece of legislation that says, unless the government can prove that a person poses a significant threat to the public, they have to be let out. So forced risk assessment. And in Canada, that's when a lot of the research and development of risk assessment instruments took off. And I think that a lot of countries have been kind of faced with that over the last 20 years, that kind of situation. We published version 3 of the HCR-20 a few years ago now, 2013. About half of the research on the HCR-20 is in forensic psychiatric settings. But as you can see, there's also a lot of research in prison settings, mixed settings, so that's, say, general psychiatry and forensic patients, civil psychiatric settings, and there's even been some research with kids, with juveniles. Over 300 studies based on, I estimate, about 175 data sets, and probably somewhere between 30 and 40,000 patients and offenders and research participants. In more than 40 countries now, there's been research and use. There's more than 20 translations of the HCR-20. I'm really happy to see the Arabic one coming along so nicely. There was a survey by Jay Singh, published in 2014, of 42 countries and about 2,400 clinicians, and the HCR-20 was the most commonly used risk assessment instrument across those 42 countries. So some basic research questions. Is there predictive validity of the risk factors? So we have those 20 risk factors. Are they actually related to violence? So basically what we do here in research studies is you rate the risk factors and then follow the patients up and look at who is violent, who is not violent, and see if there's some kind of connection between the risk factors and who is violent. There's probably now 8 or 10 meta-analyses, so this is quantitative summaries of research on risk assessment, including the HCR-20. So I'll tell you just about one of those. By Yang and colleagues, looked at 9 different instruments, including the psychopathy checklist, which is a measure of the personality disorder of psychopathy. This was 28 studies that used more than one measure, and they compared whether any of these risk assessment measures improve upon the predictive validity of the psychopathy checklist. Do they do better than if you just know that somebody is a psychopath? Okay? So what I'm going to do now is I'm going to show you something that violates all the rules against good presentation skills, because I'm going to do that. Okay? But I'm just going to guide your attention. I'll guide your attention. So these are all a bunch of different risk assessment instruments. These are correlations. So if you know about correlations, you know that they go from -1 to +1, and +1 is perfect. 0 is no correlation. So 0.37 for the HCR-20, and it's close to a couple of other measures, but then they all fall off after that. AUC values, for those of you who know, we don't have to get into detail. Those would be low from a surgical or medical diagnostic standard, but they're, in our field, reasonable. Only 2 measures added incremental predictive validity to the psychopathy checklist. So one of them was the HCR-20. That is, its strength of association with violence was stronger than the psychopathy checklist. The other was something called the Offender Group Reconviction Scale, but that's only based on 2 studies used in British corrections. Okay, inter-rater reliability. Can people agree? So if I fill it out and you fill it out, do we get similar answers? We did a study on version 3 based on 35 Swedish forensic patients. 3 raters went and interviewed each patient, reviewed their files and so forth, independently completed the HCR-20. So, more numbers for you. These are also a type of correlation, inter-class correlation. It's inter-rater reliability. ICC-1 is the reliability of 1 rater. ICC-2 is the reliability of averaged raters, the 3 averaged raters. So this is the different scales. That's for institutional violence. That's for community violence. Again, institutional and community. Final risk judgment of low, moderate, high risk. The bottom line is that inter-rater reliability was good. ICC-2s all about 0.8 and many in the 0.9 ranges. Reliability 1 is perfect, and you pretty much never see that. Predictive and incremental validity of summary risk rating. So when you use the HCR-20, you're encouraged to come to a judgment of whether the person is low, moderate, or high risk. That can inform discharge decisions or the amount of management that a person receives. It's important to know whether those judgments, which are not based on formulas or numeric cut points, they're your professional judgments, if those are predictive of subsequent violence. Again, another study with version 3 of the HCR-20. This is in 106 civil psychiatric patients and offenders. There's plenty of studies in the forensic realm on this topic as well. File plus interview was a prospective study. We followed people up 5 times after discharge. So we interviewed them and did a file review while they're in the jail or in the hospital, and then we met with them 4 to 6 weeks later, and then 4 to 6 weeks later after that, 4 to 6 weeks later after that. And it's hard to find these people in the community often. I live in Vancouver. It's about the size of 1/10 of Cairo, right? So it's a big city for Canada, about 2 million people. People who leave psychiatric hospitals and jails don't often necessarily want to come back for a research interview, so we have to go find them. So my PhD students were wandering around the streets of Vancouver at night, going into bars, trying to find their research participants. One of my PhD students actually interrupted a drug deal. So one of our research participants was buying drugs, and my student Adam went up to him and said, "Hey, is this a good time for your research follow-up?" And the guy's like, "Hey, just wait a second." So he waited patiently, and then the guy came over and they did the follow-up. I don't force my students to walk around through the back alleys of Vancouver interrupting drug deals, but some of them actually kind of like doing that. So we did a 4 to 6 week follow-up and a 6 to 8 month follow-up, looking at these judgments of low, moderate, and high risk. So again, for those of you who do like correlations and AUC values, those are good, healthy correlations and AUC values for the combined sample, for the psychiatric sample, and for the offender sample. For those of you who might want to look at a graph instead, this is the percentage of violence as a function of whether the person was determined to be low, moderate, or high risk. So judgment of low, moderate, or high risk was made by our research team, and then 4 to 6 weeks later, in the low risk group, there was 1 person was violent, so that's about 2%. In the moderate risk group, it was about 15%. In the high-risk group, it was 45%. That's in a month to 6 weeks after discharge. 6 to 8 months later, low-risk group, about 15% had been violent. In the high-risk group, about 65% had been violent. All this is showing you is that if you use this method and you use your judgment, it's a meaningful judgment. It means that if you say high risk, there indeed is a much greater chance that that person will go on to be violent than if you say low risk or moderate risk. A lot of numbers here. The general take home from this, for those of you who are research friendly, you can just read it and you'll understand it. The basic message here is that those summary risk ratings of low, moderate, and high risk do a better job at predicting future violence than if you were to just add up the risk factors. Okay? There's something about the clinician bringing their experience and expertise to bear upon a case where you can make better sense of a case through the integration of information than if we just simply added up how many risk factors a person has. I said that the HCR-20 is used to monitor change. So what that means is if you're seeing somebody develop more risk factors, you should get more worried that violence is about to happen. If they're getting better, then violence will be less likely to happen. So we looked at that in some research in Sweden, in a forensic hospital, measuring the current functioning, the C scale, the clinical factors like insight problems, violent ideation, and so forth, every 6 months for 2 years. So this is a drop over 2 years. It's not a huge drop. It's actually only goes down about half a risk factor. If you were to add up the risk factors for research, this scale can go from 0 to 10. But that change predicted violence. So for those who improved, there was less violence in the next 6 months. For those who got worse, there was more violence. But we thought we might have obscured some change. So we did a procedure called cluster analysis, which is finding groups of people who are similar to each other but different than other groups. And we found 5 groups of people who showed different types of change in risk factors. So we have this group who dropped actually quite a bit on their risk factors over time. This group dropped, but they started out higher. This group actually got worse. So they got worse for a year and a half, and then they kind of leveled off. This group started at very high risk and then got better. Okay? So again, just evidence of the basic assumption of this model that it's good for monitoring change. That if there's change, you're likely to be able to pick it up. This change is also associated with violence. So the blue bar is the HCR-20 clinical scale score over time, the blue line, and the green bar is the percentage of violence in the next 6 months. So you can see, in general, as the risk factors go down or get better, violence goes down. As the risk factors get worse and then level off, violence gets worse and then levels off. Similar study by Steph Penny, that's in a forensic setting. So what I want to do as I kind of come to a close is just tell you a little bit about how we developed and then validated the version 3 of the HCR-20. Not a lot of detail. We're always really concerned about and want input from people who use it. So we did clinical beta testing, and we had clinicians, about 45 to 50 clinicians from 6 different countries, try out the pre-publication version of version 3 on cases and give us feedback. And we made some changes based on that. Empirical testing in Canada, Germany, Netherlands, Norway, Sweden, UK, and the United States before it was published. So we wanted to make sure that it was functioning okay. And that was based on 782 participants, and there's now probably been, actually that's probably closer to 20 additional studies that have been done. What about its relevance here? So it was developed in Canada, it's used in, but now up to 42 different countries. In general, there's strong evidence for cross-cultural validity of the HCR-20. In fact, all of the meta-analyses that have tested this have found that its predictive strength is the same in different countries. So predictability does not differ across countries according to the meta-analysis. We also know that risk factors are quite similar across cultures. That is, there may be a somewhat different manifestation of what substance use problems looks like or what delusions look like in Egypt versus Canada, but they're both risk factors, okay? So there's little evidence that there are truly unique risk factors in different countries. The translation and validation plans are underway, as you've heard about, and I have been impressed with the progress. Summer, I just said something nice about you. She's like, what? I said, I just said something nice about you. The translation and validation plans are underway, and I've been very impressed by your progress.
Thank you.
So, there is a worldwide need for violence risk assessment, and it's becoming more and more evident that a lot of countries are facing the same types of decisions. There have been problems over the years with a purely unstructured clinical approach to risk assessment and an over-structured actuarial approach. We have found that SPJ generally and the HCR-20 more specifically is robust across countries, but has not been tested widely yet in Egypt, and that will change with the research plans that are underway. Are there reasons for optimism? I think there are, and that is based primarily on the fact that we've seen the HCR-20 perform comparably in many different countries, including Asian countries and many non-English speaking countries around the world. And I think there's with this kind of sea change in your laws and the emphasis on the research that is going on, I think that there are lots of reasons for optimism that the HCR-20 could be helpful in your system. So with that, I would like to thank you for your time.
Thank you, Professor Kevin Douglas, for your presentation, and we're all very excited about the HCR-20. Someone, you wanted to say something?
Yes. Thank you, Professor Douglas, for all your support and for the opportunity you gave to us to start working on the translation. I just want to highlight that the translation is spearheaded by Dr. Mona. Dr. Mona, she did all the work with her team, so Dr. Mona and Dr. Maisa are with us here from the translation team. I only did the coordination, but the actual work is done by Dr. Mona, so we'd like to applaud you for that. And I want to tell you that we are so proud of the product, and in the future it will be something that will hold our names for years and years to come for the service. So we thank you for helping us put our names on that. Thank you.
Before we go for our coffee break, we will have a panel discussion. I'd like to ask all the speakers please to join us. Professor Volm, Professor Douglas, Professor Shamrami, to join us here. And if anyone has any questions regarding the speakers, I would also like to ask Professor Dina Shukri to join us. Professor Hisham, please. راسم تفضل. The floor is open for any questions regarding any of the presentations or any questions regarding the services, forensic psychiatric services, either in Egypt or in the UK, or anything related to the speakers. في أي أسئلة حد يحب يسألها؟ صمم؟
Yes, actually, I would like to pose a question. Professor Volm, Professor Volm, is that right?
Yeah.
Okay. We saw the forensic psychiatric service in UK, and we were lucky enough to have the time to actually witness the service in High Secure. And one of the things that was very eminent in the service was the patient involvement. Would you care to talk to us a little bit about patient involvement in the forensic setting, how that is done?
Yeah, I can expand maybe a little bit on what I was saying in the talk. It is probably slightly different across services depending on how enthusiastic people are, but it's generally done in all services. So there are a number of different ways, both on an individual level and on a more organizational level. So on an individual level, it's quite clear that all patients are involved in their treatment plans and in their treatment reviews, take part in those, and that we try to work collaboratively with the patients. There are even some places now where the patients contribute to the HCR-20 decision making or do their own risk assessment. We have also tried for patients when they have their review meetings that they write their own reports about the progress they have made. As well as the professionals writing those reports. And then on a more systemic level, there are patient councils which provide input into service development, make suggestions about how services could be developed, and patients have some roles, as I said before, for example, in interviewing panels for the appointment of new doctors, for example, nurses, psychologists, and we also provide training for them. So if somebody is interested, we give them a one-day training about what questions to ask in an interview panel, what questions not to ask, how it's done. They would be part of a panel like professionals. Other examples would include the assessments of other services, quality assessments, and for example in research where we would ask patients what topics they think would be relevant to research, and again we have trained some patients, for example, to do qualitative interviews of other patients with supervision, but to train them some basic research methods and for them to contribute practically as well to the execution of the research.
Thank you. Professor Dina Shukri has a comment, please.
Hi everybody. I just want to extend my greetings to Professor Dr. Tariq and Dr. Samar, and I want to express my appreciation to Professor Birgit and Kevin and Professor Kevin Douglas for the fruitful and very precious lectures that we had, and we are going to have tomorrow, inshallah. And I want to take the advantage of being here with the forensic experts as well as for the psychiatrists to extend the services for the forensic psychiatry, of course, competence and capacity, and assessing the risk assessment and the discharge of the mentally ill offenders is a very important issue, and it is of a great humanitarian effect in the Egyptian society. But I want to add another aspect of forensic psychiatry, which is the rehabilitation for the survivors of the violence, whether it is within the context of the family, domestic violence, or within the society as a whole. Because we do have a lot, and we need to have some kind of integrated, standardized services that we will offer to them, starting with the first aid, how to communicate and contacting and interview, and how to document all in order to be presented in the court, and how to help them for the behavioral therapy and support from the family and the society in order to be more convenient to them to live in a better lifestyle, and of course in order to rehabilitate them. So we need some kind of integration between forensic medicine, psychiatry, psychology, and sociology in order to offer them some kind of better management for their cases, and in order to have a strategic plan how to combat violence that become prevalent in the Egyptian society nowadays.
Thank you. I believe this is a strategy and an idea of what you look. Maybe Professor Hisham Rami can tell us what is actually happening now from what you are saying and what are the plans in the future to do things.
Thank you, Professor Dina. A very interesting topic to discuss. But fortunately, one of the few things that we have developed in Egypt is actually having a unit to manage children, adolescents who are victims of violence, and now the service is being extended to others. It's a very unique service in Abbasiyya Mental Hospital, and the name of the service is WAHA. So in English it would be the Oasis Clinic. And they have been working since 2011, if I'm really accurate in the dates. Dr. Tamer, WAHA بقى لها قد ايه دلوقتي؟ 4 سنين. So it has been working for 4 years now. They have great experience in managing victims. They document everything. لو أنا فاهم صح مش كده؟ طبعا there is a little bit of political orientation, so it's torture victims as well and stuff like this. But domestic violence, child abuse, right? Adolescent abuse, and now they are extending the service to others. We also have a new service which is, how do you call it? Disaster psychiatry or disaster team, which is a mobile team, and it moves whenever disaster happens. They have been trained. The team is composed of a psychiatrist, psychologists mainly, social workers, and even nurses. So they have the service, but it's not a national service. It's still, how do you say, it's like a pilot unit, but they have trained people in Alexandria, in other hospitals as well, and they are moving around.
كان في سؤال اتفضل حضرتك. سؤال لمين؟
سؤال دكتورة منال ودكتور هشام. First, thanks for being here today. Thanks Dr. Benan, thanks Dr. Samar. Thanks Professor Kevin for your lectures. My question is about the medium and the low security hospitals now in Egypt, because after we have learned that there are, it become mandatory for us not only in the management of during the management and the release approach of the high security patients, but it also became a mandatory during the assessment of the high security patients or the middle security patients or the low security patients. So it became a mandatory to know the plans about this.
The question is very saddening for me. Okay? It means that my lecture was not understood by all people. Although I try to speak in Arabic, and I try to be as clear and simple as possible. During my presentation, I emphasized the point: the system in Egypt is a very simple system. There are no levels of security. There are only high security units. There are no low security units. There are no medium security units. Part of the development strategy that Dr. Hatem supposedly is leading now, and he has done a great job doing it, and hopefully it will succeed with Dr. Mena, of course, is developing a system which has different levels of security, but this will depend on what is known as measurement-based services. It has to be, how do you say it, validated, reliable, skills, and then you can move people from different levels, but we do not have this. We only have high security units, very centralized. Only 2 units in all Egypt. The Egyptian population is now 100 and something million population, 104, and we have 27 different districts or 27 different governments, but we only have 2 units. These are, how do you say it, typical high security units. We even have police force surrounding the units from outside, and we need to develop the services. But in order to develop it, what Dr. Hatem is doing, training, having personnel able to do the service, and then do this. It seems that my lecture was not clear.
No, I'm talking about the future work.
This is what Dr. Hatem is doing.
هي كنت عايز بس اقول ان احنا في مصلحه الطب الشرعي في عيادات فتحنا عيادات للعنف ضد المراه وبدانا نعمل فيها سايكولوجيكال سبورت. فاحنا في اشد الحاجه الى ان يكون الناس اللي شغاله في الطب النفسي تبقى معانا سبورت للموضوع ده. فاحنا كمصلحه الطب الشرعي نتمنى مشاركه كل الاساتذه وكل الناس اللي بتشتغل في الطب النفسي معانا احنا دلوقتي على مستوى القاهره بس شغالين في الدعم النفسي، لكن كل العيادات اللي احنا بدانا نفتحها بتمنى ان كل الاساتذه اللي معانا يشاركونا ازاي نرفع مستوى الدعم النفسي في العيادات دي. كمان احنا في مصلحه الطب الشرعي واحنا بنتعامل مع تقدير العاهه والكلام ده في الاصابات، ما بنتعاملش غير مع تقدير العاهه في تقدير العاهه للاصابات البدنيه فقط، لكن احنا بدانا ندخل ازاي العاهه النفسيه في الموضوع، وده اعتقد انه برضه اتمنى ان كتير من الاساتذه في الطب النفسي يشتغلوا معانا. حتى احنا في قضايا الاخطاء الطبيه، انتوا عارفين الخطا الطبي بيبقى او قضايا المسؤوليه الطبيه عموما بتركب من 3 عناصر: خطا من الطبيب، وضرر من خطا من الطبيب، وضرر وقع على المريض، وعلاقه السببيه ما بين الخطا والضرر. فكان قبل ما انا اجي كرئيس مصلحه الطب الشرعي كان كل المشكله كانت ماشيه كلها ان احنا نتعامل مع الضرر الصحي فقط اللي وقع على المريض. عشان كده كانت نسبه الادانه للاطباء حوالي 17% في كل الشغل اللي بنشتغله. احنا دلوقتي يمكن الدكتور علاء دلوقتي معانا قاعد معانا، عارفين دخلنا الضرر النفسي نتيجه اخطاء الاطباء. طبعا نقابه الاطباء عايز تضربنا بالنار دلوقتي، لان احنا وصلنا دلوقتي لحالات عدينا 30% من الادانات بتاع بعد ما دخلنا الضرر النفسي فيها. برضه احنا في شغلنا محتاجين ان مصلحه الطب الشرعي اي حد محتاج، اولا احنا كفيل للريسيرش احنا ما عندناش مشاكل خالص ان اي حد يجي يشرفنا معانا يجي يشتغل على الفيكتيمز بتوعنا. اي حد عايز يجي يعمل سبورت للحالات برضه ما فيش مشكله بالنسبه لنا. الهدف بس ان احنا نرفع المستوى العلمي عندنا ونرفع المستوى الصحي للناس. فارجو يعني انه اي حد شايف انه ممكن يساعدنا في المجال ده احنا في مصلحه الطب الشرعي بنرحب بيه على الرحب والسعه.
استكمالا بس الكلام حضرتك دي حاجه مهمه جدا، لان انا فاكر كان بعد الحرب بتاعه العراق والكويت وحصل الغزو من العراق للكويت، كان في لجنه من الامم المتحده راحت عشان تدي تعويضات للناس، فكان بيقولوا مثلا اللي ايده اتقطعت هياخد كتلا يعني $100، اللي ايده رجله حصل لها حاجه اللي عينه. بعدين قرروا اللي تعرضت للاغتصاب، الطفل اللي شاف ابوه بيتقتل، الزوجه اللي شافت زوجها بيتقتل، التعويض ده هيبقى كام؟ يعني احنا ممكن نقول عين بكذا، الودن بكذا، الرجل بكذا، بس التعويض النفسي هيتحسب ازاي؟ فما كانش عندهم اي مقياس يقيسوا بيه التعويض النفسي ده، فقرروا يشوفوا اكتر فلوس بتتاخد في العاهه الجسديه ويبقى هو ده التعويض النفسي اللي موجود، لان ما كانش فيه مقياس ليها. فكلام حضرتك مهم جدا ان السايكولوجيكال كومبوننت او السايكولوجيكال ابيوز او السايكولوجيكال ستريس اللي بيحصل زي بالظبط الفيزيكال اللي ما كانش اكتر كمان. وبشكر حضرتك على الحاجه. السؤال اتفضل.
السؤال هو بخصوص ايه الموانع؟ الدكتور هشام، دكتور منان، دكتور حاتم، ايه الموانع اللي تمنع ان احنا نعمل نظام متابعه للمرضى الفورنسيك بعد ما يخرجوا؟ وامتى نلاقي النظام ده؟
اعتقد الموانع هي الموانع اللي واقفه قدام اي متابعه للمرضى خارج المستشفيات. يعني فكره الكيس مانجمنت والانترميديت سيرفيسز دي حاجه مش تطبيقها، حاولنا نطبقه كتير وما بيبقاش ناجح قوي، لانه البيرسونال اللي بيحاولوا يشتغلوا في المجال ده بيبقوا قليلين جدا، وطبعا العائد المادي قليل والمواصلات والحركه الكتير والصد من المرضى، يعني في عديد من المشاكل بتقف قصاد. بس ممكن جدا ان احنا نرتبها ان شاء الله ويتعمل خطه للتصليح ده باذن الله.
وبعد اوريدي احنا عندنا بروتوكول لازم اي مريض بيطلع من الايداع بيبقى فيه بروتوكول ان هو فولو اب لمده 6 شهور، وبعد 6 شهور احنا لا اما بنأسس ونقول ان هو محتاج يكمل او لا مش محتاج يكمل. والفولو اب بيبقى في المستشفى القريبه منه، يعني لو هو في الصعيد بيروح مثلا مستشفى اسوان، بيروح اسكندريه، فاوريدي احنا عندنا سيستم. لكن زي ما حضرتك قلتي ان يمكن
الاستمراريه صعبه.
لو ما جاش المريض للمتابعه،
ده الجزء اللي انا كنت عايز اتكلم فيه. دكتور هشام ودكتور هشام رامي استاذنا كان عارف ايه يعني احنا زي الدكتور وائل ما قال في بروتوكول متابعه ما بعد الخروج. الكريمنال او المريض المودع لما بيخرج من السيرفيس بيتابع في المستشفى لفتره والامور بتبقى مستقره وكويسه، وبعد كده بنحيل المضمون بتاع العلاج او الخطه العلاجيه بتاعته اللي اقرب مستشفى دي وبيتابع معاه. ده الاجراء اللي بيتم لما تبقى الدنيا سموث. السؤال اللي حضرتك سالته دكتور هشام ده بقى ده مهم قوي. لو المريض ما جاش، احنا تواصلنا مع مكتب النائب العام في فتره قبل كده، ايه اللي ممكن نعمله لو مريض عنده باست هيستوري ان هو يعني اوفندر كان عمل قبل كده وما جاش يتابع. احنا كنا عايزين ان يبقى في آلية تساعدنا فيها وزارة الداخلية او وزارة العدل ان احنا نستدعي الشخص ده بطريقة او باخرى. للاسف كان الرد علينا من مكتب النائب العام ان ما فيش في القانون المصري في الوقت الراهن ما يسمح لنا بكده. ليه؟ لان هو عقوبته انقضت بالمحكمة، فما يقدرش ان هو يستدعيه الا اذا كان عمل عقوبة اخرى. احنا كنا بنحاول، كان نفسنا ان انا باي اكسبيرينس الراجل دوت عنده باست هيستوري اوف منتال النس وهي كوميتس ان اوفنس. انا مش لازم استنى ان هو ينتكس علشان يرجع يعمل جريمه. للاسف ما عندناش في القانون الناس.
الحقيقه دي مشكله كبيره في كل بلاد العالم مش بس في مصر عشان بس نبقى واضحين يعني. وكان التصور اللي قعدت انا مع الدكتور حاتم وتصورناه كويس، وان شاء الله الدكتوره منى يعني تقدر تنفذه باذن الله، يعني ده حاجه هتتكتب في حسناتها. والاتي العيان خرج هيروح لاقرب مكان الى منزله، لكن هذا المكان لازم يكون فيه ما يطلق عليه الكوميونتي تيم، عشان لو العيان ما جاش نروح له مش ولا لا ونعامله زي اي عيان. لو لقيناه بينتكس قدام عينينا مش ولا لا هيبقى اصبح يشكل خطوره، فنطبق عليه القانون العادي. احنا عندنا قانون اسمه قانون 71 لسنه 2009 يقول لو حد بيعاني من مرض نفسي مش ولا لا واصبح يشكل خطر على نفسه او على الاخرين، انا من حقي كمنتال هيلث سيرفيس ان انا اخده وادخله المستشفى. ولو قاومني انا من حقي ابلغ البوليس او النائب العام يجيبولي. انت فاهم قصدي ولا لا؟ من غير هذا الفريق تماما مش هيحصل حاجه. لكن فكره ان فقط اعتمد انه هيجي المستشفى اول ما يجيش هو مش هيجي. فاهم قصدي ولا لا؟ ما هو هتجيبه ازاي من غير ما نبعت لها تقييم انه اصبح منتكسا ويشكل خطوره على نفسه وعلى الاخرين. فعشان كده في الدنيا كلها اتحلت. عندي ما يطلق عليه فريق طب نفسي شرعي مجتمعي. يعني ايه؟ عندي اخصائي اجتماعي وعندي ممرض او ممرضه وعندي دكتور او كذا دكتور على حسب عدد الفريق. اللي ما بيجوش بكل بساطه بعمل ايه؟ بروح لهم زي اي خدمه في الدنيا. انت دلوقتي ايه اللي خلى ماكدونالدز مبيعاته زادت مثلا؟ ان انا باجي لك مش ولا لا؟ انت مش لازم تجي لي المحل تشتري مش ولا لا؟ ده انا بروح لك. فكل ما الحاجه هتبقى ان انا في خدمه ان انا بروح لك، كل ما هتقدم خدمه افضل ومتابعه افضل. زي ما الدكتوره منى هانم قالت، ايه اللي بيعيق ذلك؟ اولا عدد العاملين، العدد، كفاءه العاملين. ايه الانسنتيف اللي هتديه الواحد انه بدل ما يجي الصبح من المستشفى عادي خالص زيه زي بقيه الناس ويمضي ويقعد، هيركب ويروح، فلازم ده يبقى له انسنتيف زياده مش كده لا؟ فاذا هناك بعض العوائق اللي ان شاء الله تتغلب عليها ماليه مش كده لا؟ هيومن ريسورسز والفكر. يعني ممكن الكلام ده جميل مش كده؟ انا عمال اقوله نظري بقوله بقالي سنين يعني. المهم تغير فكر الناس اللي هينفذوه وده هيبقى شيء جميل يعني.
Okay. Dr. Hisham, may I just extend the question to Kevin? Kevin, to what extent do you see violence risk assessment tools like the HCR-20? I know it's beautiful, of course, because you're the author and because it is a very good tool, of course. But to what extent do you see application of tools like this in forensic settings capable of solving problems like the problems of patient promotion into the system in systems like ours where there are no medium and low secure settings at the moment? Of course, we're waiting for a big progress to be implemented by Professor Menon in her presence in the General Secretary of Mental Health, of course. But for the time being, we don't have anywhere for patients to progress. Where do you think the HCR-20 as a tool can fit in this system?
Well, I think in general it's intended to help you make decisions about the types of services and management and treatment that a person needs, and that's contingent on the level of risk that they pose. So how it fits into a system is to help you make decisions about managing their risk, whether they all stay on one high-risk unit. I don't know if it's possible within a hospital that's designated as high risk to have gradations of security within that same hospital until you actually have separate hospitals that are medium or lower term risk. In the province that I live in Canada, British Columbia, we have one forensic hospital and it's maximum security. But within that hospital, there are high secure wards or units. There's medium secure, there's low secure. People can have supervised leave, so they can leave the hospital, say, for 3 hours with staff members. Then they can work up to having unsupervised leave, so they could leave the hospital for 3 hours by themselves. They can work up to having 1 or 2 nights in the community as kind of a graded, gradual testing of how well they might do in the community. And the HCR-20 and other risk assessment instruments are used to help make those decisions. What sorts of risks might be posed if they go from a high secure unit to a medium secure unit, or what risk level would they pose if they had supervised leave or unsupervised day passes. So it may be that even without having separate hospitals, and I don't know if this is possible because I don't know how you've structured your hospitals, but
this is actually proposed by Professor Hisham when he used to
okay. But having different levels of restriction or supervision within the existing hospital and day passes and so forth. Having community outpatient offices could be helpful. I agree with the comment that expecting the patients to make their way back to the hospital, they might not always want to do that. That's why in my research project, I sent my PhD students out to wander through the streets of downtown Vancouver looking for our patients. So it is used in that way in a lot of settings around the world. We use the term cascade people down into lower levels of security, or increased privileges as the case may be. So there's flexibility in that regard.
Can I add one sentence? As I was saying about the UK system having completely separate hospitals being managed by separate, directors and so forth for the different levels of security is actually not an advantage as such, because it leads to a lot of inefficiency and so forth. So having different levels within the same hospital is a much better way, I think, to manage things, and that is what, for example, the Dutch system, which also has a very long history of forensic services, does, and in Germany as well, places do, and that has the advantage that it's within the same treatment approach, it's the same director, it allows relatively flexible, fast move from one ward to the other without having to wait potentially for a long time, without having potentially arguments between treatment approaches. So if something of different levels of security or restrictiveness even could be implemented in the same hospital, I think that would be a better way of doing things.
Mona, you had a question?
I was asking Professor Douglas, thank you for your lecture. This meeting is quite rare in the fact that we have the author and we have the implementers, and a meeting like this would not happen a lot. So once we finish the translation and it's approved, what are the precautions that you'd caution us against, especially when we're first using the HCR, that take care of overdiagnosing, take care of anything else? What are the precautions that we need to take care of?
That's a great question. I think I can give you some initial thoughts about that based on my observations of other systems that have implemented it. I think it would require a longer dialogue, which I'm happy to talk to your group about. I would caution against thinking that the mere fact that you train a group of people to use the HCR-20 or anything, that they're actually going to use it by mere virtue of having been trained. So I think you should have a plan in place to, if you train a group of clinicians at a hospital, that's one step. There's steps before that, such as raising awareness, a gentle introduction to the idea of, say, structured violence risk assessment, making sure that people understand that this approach is not intended to take their jobs away. It's actually, it values professional judgment.
Yes.
This approach cannot be used without the expertise of the people using it. I like to give the example, and I talked about it with our group in the training, about pilots who fly airplanes. And do you remember when that plane landed on the Hudson River in New York? Mm-hmm. So it took 69 seconds after takeoff for it to hit a flock of birds and lose both engines. And the control tower said, oh, divert to this runway over here. Pilot said, no, can't do that. Gonna land in the river. In that 69 seconds, the co-pilot took a manual out and read through, what do you do if you lose your engines? What do you do if you need to land on water? And they did what they needed to do, and they landed on water, and nobody died, and it was actually quite amazing. So that was professional expertise within a structure. So people really have to know that their professional expertise is still valued. So having a pre-plan in place, even before the training, and then identifying what is often referred to in the implementation world. There's a whole implementation science literature out there. How to successfully implement tools, measures, procedures. Is identifying local champions. So within a unit or a ward or a hospital or a service, try to identify a small number of people who are well respected by administration and by their peers, and who can advocate for the use and adoption of whatever it is you want them to use or adopt. So valuing people's professionalism, preparing for it in a way that people realize this is actually going to help them do their jobs and help them help patients, which is why we're all in this field, right? And then afterwards, post-training, people need the opportunity to practice. So they need to be able to have the time to further their skill base. So in training, you learn how to do something like the HCR-20. Having some practice cases can certainly help out. And having kind of a gradual implementation of it so that people become comfortable with it, and it's not that it's just kind of dropped on them. I've seen it work really well in many large systems. I've also seen it not work very well. Tends not to work very well, and this is not just the HCR-20, the other risk assessment instruments, personality measures, whatever the case might be, when it's kind of like, it's perceived by the staff as, well, here's somebody coming in telling me how to do my job. People might fill it out and then put the piece of paper on a shelf and ignore it. Right? So I think there's, looking at the implementation science, there's a lot of kind of proven methods and techniques to help out.
So I'd like to highlight that the local champions were already chosen by the General Secretary of Mental Health, and they're being trained for 3 consecutive days. So just consider yourself the local champions for the upcoming era.
Okay, we'll have one last question from Dr. Hisham Rami, and then we'll ask Dr. Samar to close the session.
Can we close the translation and speak only in Arabic? Our visitors should not listen to what I'm saying. السؤال برضه للدكتورة منى، أنا معجب بقدرة حضرتك على ترجمة ال 130 صفحة إلى اللغة العربية ومعرفتي بكفاءة حضرتك في اللغة الإنجليزية وليس العربية.
لا في 8 بيساعدوها، هي اللي هتعمل الإنجليزي مش العربي. هي هتعمل الإنجليزي مش العربي. سمر.
Okay, I'd like to finally thank you all for being here today. I want to thank specifically Professor Dr. Tariq for leading his clinic today and being with us, and all the psychotic patients. He said they have my address now, so they'll be coming to pay me a visit tonight. Thank you, Professor Menon, for being with us today. Without you, none of this would have happened, of course, so thank you for making this event happen. Thank you, Professor Hisham and Professor Hisham, for being with us today and for all your support over the past year. So thank you very much. Professor Dr. Dina, representing today our stakeholders and representing other universities that are with us and endorsing our LIFE project. So thank you very much to Cairo University for being with us on this project. You're always very supportive to us. Thank you very much for our guests. Thank you, David, and thank you, Kevin, for being with us and for all the information we got from you over the past few days, and we'll still be with you for another day. Professor Dr. Asim, thank you very much for being with us today. Professor Dr. Asim is our mentor, and without him, nothing would move inside the university, so thank you very much for all your support and for being with us today. I want to invite you for just a small coffee break just before you leave. We decided to leave it to the end just to make sure that we will enjoy it together and have another discussion over coffee for the next 15 minutes. Thank you very much. بعد اذنكم